Hello everyone, welcome to our first video for the high yield hump days that will be surrounding differential diagnoses. So today we're going to take things a little differently. We're going to give you a vignette and have it be very vague, talk about the different possible options that can spin off of that vignette, and then go through all the different ways that we should be considering treatment and or diagnosis for these different cases. All right, so let's start off with our first vignette. We have a patient that comes in. They have fatigue, weight loss, and abdominal discomfort. So when we think of those three symptoms together, there's a lot of different things that we can think of, right? Some sort of cancer. They have fatigue, weight loss, abdominal discomfort, right? We could think of some sort of autoimmune condition that could lead to something. We could be thinking of some sort of abdominal related condition in terms of hepatitis or maybe not really some sort of appendicitis, but because that would be an acute presentation, but maybe some sort of gallbladder disease or pancreatitis. A few different things that we can kind of think of here. All right. So we're going down this first route. Now we get the completion to the scenario, and we hear that this patient has hyperpigmented skin, salt cravings, and low blood pressure. So when we see this triad of symptoms on top of the fatigue, weight loss, and abdominal discomfort, this patient is going to have something like Addison disease. Is the chat? Oh yes, perfect. Okay, yeah, cool. I just wanted to make sure. So in this case, Addison, which you'll also call it like primary adrenal insufficiency as well, as opposed to secondary, which is something not in the gland, right? When we think of primary versus secondary issues, primary is going to be the actual organ itself, so the adrenal gland, versus secondary is going to be something like ACTH secretion coming from the pituitary gland. That's how we differentiate between primary and secondary. So in this case, Addison's disease, we're going to get this hyperpigmented skin. Why? Because if we don't have a functional adrenal gland that can make cortisol and aldosterone, then we're going to keep secreting ACTH. ACTH secretion, ACTH itself, the molecule itself, is not what stimulates melanocytes. However, there is a precursor molecule that's very similar to how melanocytes are stimulated. So when you have a lot of ACTH, it often will result in a lot of melanocyte stimulation. All right. So that's how we get that hyperpigmentation. When we think of salt cravings, well, in these patients with Addison's disease, we have no cortisol and no aldosterone. All right, with aldosterone, normally the mechanism for aldosterone is that we're trading sodium for potassium. Well, in this case, if we don't have aldosterone, then we're going to lose sodium and we're going to have a lot of potassium. All right. So we're not going to retain potassium to the point where we're going to have torsades, but we're going to have a lot more potassium comparative to sodium just because we don't have aldosterone. All right. And then low blood pressure, that's also due to the fact that we don't have aldosterone and we don't have cortisol, right? So low aldosterone, we don't have that renin-angiotensin system that can function, and we have low cortisol. Cortisol also helps increase our blood pressure, especially during times of shock, that kind of thing, right? So this is how we see that hypotension. All right. And then tying it back to the original symptoms with the fatigue, the weight loss, right? In patients with Addison disease, they're probably not having the greatest time in terms of the shock they're going to feel when they don't have cortisol, right? They're going to be hypoglycemic a lot, probably. And then in terms of fatigue, they're probably going to be exhausted without cortisol. You don't have that rush, that shock of, hey, I'm sick, I need to go do XYZ, right? So we're going to be thinking of Addison disease here, all right? And the big thing to remember, these are all going to differ with some major symptoms. So we just need to make sure that we're checking, okay, do they have some sort of hyperpigmentation? Do they have low blood pressure? Like, how are we going to differentiate these, all right? And then how are we going to treat Addison disease? Typically, you're going to give two different types of medication. You're going to give steroids, so glucocorticoids. Let's just say something like dexamethasone type thing that we would test them for. You could give them something like that, or something like hydrocortisone. And that'll be our steroid, and then fludrocortisone. And that'll be our mineralocorticoid. All right, so this is the gluco, and this is the mineral. Gluco meaning it'll take the place of cortisol, mineral meaning it'll take the place of aldosterone. All right. All right. Let's move on to the second phrase, where now we have the same set of original symptoms: fatigue, weight loss, and abdominal discomfort. However, now we have jaundice, dark urine, and elevated liver enzymes. So for someone who's coming in and they have fatigue, weight loss, abdominal pain, right? And then now we see they have jaundice, elevated liver enzymes, we have some sort of hepatic disease, right? And this is probably going to scream some sort of hepatitis to us. Hepatitis has two acute versions, right? A and E. That's why when we write out acute, we say A and E as the two acute versions. They're going to cause LFTs greater than 1,000, right? And there's only a few things that cause LFTs greater than 1,000, right? We remember it with bats. That's going to be viral hepatitis, autoimmune hepatitis, toxic, as in like some sort of drug overdose, like acetaminophen, and then shock, that's from ischemia. All right, these are the only 4 instances in which you'll have LFTs greater than 1,000. So if someone has LFTs greater than 1,000, we're not going to think of some random like choledocholithiasis or something, right? But if they don't have LFTs greater than 1,000, then we're also able to rule out some of the major things like acute hepatitis. Okay, but in this case, when we have the hepatitis, we're thinking of, okay, what are we looking for in terms of treatment, right? Oftentimes for these guys, we're just going to give them supportive treatment, right? Depending on the type of hepatitis. Hep B and Hep C are more chronic types of hepatitis. We're not going to have that acute picture that we would see going on. And then from there, when we're thinking of what types of things to avoid, we want to avoid hepatotoxins, right? So we want to avoid things that'll make it worse. Probably going to want to avoid a lot of acetaminophen, right? Probably going to want to avoid things that will accumulate if we don't have a normal liver, right? Drugs that will typically be recycled or broken down by cytochrome P450, we probably don't want those, right? Because they're probably going to accumulate toxically, all right? We want to make sure we're hydrating them, and then we want to make sure we're monitoring their synthetic function. The best way to determine acute liver failure in a patient, and by acute liver failure, I mean the point where they are beyond repair, they need a liver transplant, they need to be transferred to a liver transplant hospital that can take better care of them in order to coordinate a transplant, is to test the PT-PTT. All right, because these guys have such short half-lives that we're able to tell when the liver has officially reached that acute liver failure stage, all right? And this is because typically the liver is producing a lot of proteins, including these guys, our factors, right? But in this case, if we lose all of our factor production, then that means our liver has officially failed. And we need to fix this liver in terms of a transplant. That's the only way this patient's going to survive. All right? Okay. Moving on to our next one. Now we have a patient, again, the fatigue, weight loss, abdominal pain. Now we have polyuria, polydipsia, elevated fasting glucose. Now we're thinking diabetes, right? Type 2 diabetes. If I said type 1 diabetes, that'd be fine. I'm just kind of picturing an older patient, but let's just say diabetes in general. So I'll go with diabetes mellitus in general, because we're going to see these exact same symptoms regardless of whether or not it's a child or an adult presenting with type 1 versus type 2. All right. So we're going to present with diabetes mellitus. There is a difference between what kinds of symptoms what kind of labs values they would present with, but oftentimes they're going to have very similar presentations in general. All right. In this case, diabetes, we're thinking of the high glucose, right? They're going to have something like above a 125 on a random glucose test. Let's see, their A1C is going to be something like 6.5 or greater, right? So if we're thinking of pre-diabetes, that's between that like 5.7 to 6.5 range, and then above 6.5, we officially have diabetes. And technically speaking, this is where it's like somewhat of a paradox, but we want patients with diabetes to have an A1C less than 7. That's like their goal. When they're elderly, their goal is less than 8, and that's fine. But it's almost weird that when they're diabetic, we want them to have a less than 7, but the definition of diabetes is greater than 6.5. So it's almost like we're okay with them still being diabetic as long as they're less than 7. But It's kind of weird, but that's kind of how we do things. The big thing of why we want the A1C to be low, glycosylation of a lot of different proteins and enzymes and all these different structures are going to cause issue, right? We're going to have those microvascular issues. Patients with diabetes are going to have the retinopathy, the nephropathy, the neuropathy, right? All these different things are occurring at a microvasculature level. It's a small vessel disease. That's why diabetes is something we have to treat aggressively. Eventually, they can have a STEMI. Eventually, they can have a stroke. All these things are associated with diabetes. All right. Typically for pre-diabetes, I think it's like 5.7 to 6.4, but it can also depend on which hospital system, what their reference range is, that kind of thing. Because I know there's lab values that I see on test questions that it's like, oh, the sodium normal is something like 138 to 148 or something, and then my hospital is like 135 to 145. Like a random example of like how sometimes the numbers can vary. Okay. So in this case, we're thinking diabetes, right? A1C greater than 6.5. We want to give them medications, right? Depending on if it's an adult or a child. If it's a child, that means they likely have the autoimmune version or they just can't make insulin in general. So we might want to give them something like insulin, right? And give them some sort of pump that's a continuous pump, right? And then if it's an adult, maybe we want to give them something like metformin. Lifestyle changes, right? And then if we need to eventually, nowadays we have the GLP-1s. Oftentimes they are helpful with diabetes, and actually in some states and some insurance programs as well, now they're only covering GLPs if it's for a diagnosis of diabetes. They're no longer covering it if it's only for weight loss, right? But in this case, again, we start with the fatigue, the abdominal pain, and now we add a couple more symptoms and we get diabetes. So this is how I want you guys to be framing your differential when as you're reading through a question. Like you see someone coming in with abdominal pain, you're like, all right, could it be something like diabetes? Okay, what else would I expect? Okay, is this something like hepatitis? What else would I expect? That way, at the end of each question, at the end of each vignette, you are ready to say, okay, the diagnosis is blank. I need to look for this answer choice. Because the big thing is if you're looking at the answer choices blindly, just hoping that something will come to you, like, oh, it's this protein, you're going to miss out on a lot of question because 80 to 90% of the path is just trying to figure out what the disease is or what the diagnosis is. From there, it's a matter of trying to remember, oh, well, in general, this diagnosis is because we have some sort of protein deficiency. I'm going to go with an answer choice that kind of matches that. So that way you're kind of working through problems, even if you don't remember what the answer might actually be. All right. Okay, let's move on to this next one. We have someone who has, again, the fatigue, weight loss, abdominal pain. Now they have chronic diarrhea, iron deficiency anemia, and symptoms improve with a gluten-free diet, right? Gluten, anytime you see gluten, we're going to think celiac disease, right? What is celiac disease in terms of the underlying mechanism? It's that antibody and IgA that's being produced to things like transglutaminase, right? Or endomysial IgA, that kind of thing. But it's IgA that's being produced to all these different structures. If you test them for celiac disease and it comes back negative and you really suspect they might have celiac disease, you need to test their IgA levels because they could just have a selective IgA deficiency. And in which case, their IgA is going to look like it's low, so they don't have celiac disease, but in general, they might all be low. And so the celiac is presenting in different ways, but it still is celiac disease, all right? Why do we have these symptoms? Chronic diarrhea. Well, it's essentially an osmotic diarrhea, right? We're not able to take in any of this gluten that is inside of our GI tract, right? And typically, this is what we would call a brush border enzyme deficiency or brush border atrophic villi, right? So in this case, when we're thinking of this, that means that we're going to leave all this gluten in our GI tract. When it reaches further down in the colon, things like that, it's going to be hyperosmolar, right? We have too many structures inside of our GI tract. We need to put more water into it because our body doesn't like things being out of order, things being out of equilibrium, right? So we're going to dump water into it, and that's where we get some of that diarrhea, all right? From there, when we're thinking of the iron deficiency anemia, why do we have iron deficiency anemia? Where is iron absorbed? Iron is absorbed very proximally, right? In the duodenum, typically, very early jejunum, if anything. So if we have an issue, the celiac disease location is typically in our duodenum, in our jejunum, right? So we're going to have issues with some of those minerals and vitamins that we're trying to absorb very early on, right? So in this case, if we have that condition where we don't absorb things well, then we're going to have issues with duodenal absorption. And that's going to remove some of our possible iron that we get in our diet, all right? So this is something like celiac disease, and treatment for them, just avoid gluten. That should fix everything, right? That should get them back to normal. Avoid anything that's gonna cause the triggers. They should be good to go. It's a pretty convenient disease to be able to avoid nowadays. I remember my sister had celiac disease when I was younger, and we'd go to like stores like Wegmans or whatever, Market Basket, and you could find like maybe 10 total items in the entire store that were gluten free. And so my sister's supposed to be able to eat like, whatever meal she needs to eat throughout the day, and only have like 10 total items ever that she could possibly rotate through as her daily lifestyle. Like it was not working, and we felt really bad in terms of like, okay, we can try to make you this, we can try to make you that. Sure, there's plenty of things that can be gluten free, but you get tired of rice eventually, or you get tired of just the same old vegetables every time. So definitely nowadays they have much better selections options for people, and it should be a lot easier to be able to avoid gluten. All right, then our last set for this initial abdominal pain, weight loss, fever, and fatigue. Now we have fever, night sweats, painless lymphadenopathy. These are all some B symptoms, right? When we're thinking of B symptoms, now we have some sort of lymphoma. Which type can be various different types. We're non-specific in this case, but at least with the painless lymphadenopathy, we probably have some sort of lymphoma that's metastasizing and going to all the different lymph nodes, that kind of thing, right? The fever, that's very typical because we have a lot of different immune system interactions with the B cell, right? Typically, this is a B cell, I guess, hyperplasia, but it's like immortal lineage. I call it an immortal lineage because they keep replicating. It's very hard to get rid of them. From there, we also have the night sweats. That's very common with cancers, right? That's why we call them B symptoms. Typically, this is going to require treatment with chemotherapy, right? And then there's special considerations we might have to make of which type of cancer it is. Should we use something that goes after certain types of body cells, just because if the patient has a history of nephrotoxicity or something, right? We have to be careful with some of the medications we give, but in general, this is going to be some sort of cancer. When we have fever, night sweats, etc., abdominal pain, we're thinking of some sort of lymphoma. All right. So this is our first set of the diagnostic criteria. And then here's a little chart as well. And I made a nice little diagram for each of these. So it's going to give you a nice breakdown of, okay, if we present with fatigue, abdominal discomfort, what do we think of next? Okay, think of some sort of Addison disease. Well, how were their labs? Did they have some sort of high potassium, low sodium? Or do they have the symptoms of hyperpigmentation, salt cravings, right? Or did they have polyuria, polydipsia? Now we're thinking more of a diabetes tract, all right? Do they have some sort of chronic diarrhea? Okay, maybe we're thinking more of a celiac disease, lactose intolerance. We can kind of go down that route, right? So there's a lot of different things that we can think of in terms of each diagnosis, and I want you to break down these questions saying, okay, what symptoms would I expect if it's this? If I had hyperthyroidism, I would be expecting the patient to have diarrhea and sweating and palpitations, tremors, etc. If the next line tells you that the patient is having constipation and is having something else, that we're not going down that hyperthyroidism route anymore. Now we've switched to a different part of our differential. All right. That's why I want you guys to attack these exams, is just to say, okay, what is my differential? Is this what you're going to do on test day? Most likely not. On test day, you're just going to read the questions and go through selecting answers because you know what it is by the end. But realistically speaking, I did this a lot as well. On the questions that you're stuck and you're just like, dude, what is this answer? Like, I do not know which enzyme, I do not know which condition. That's when you can turn back and say, okay, what might my differential be? What is this patient presenting with? What are we expecting if it was this? What lab would we get? Oh, they don't have jaundice. Okay, then it can't be this. And that's how I want you guys to attack this exam, all right? Let's move on to our second vignette. We have a patient that comes to the emergency department with acute chest pain and shortness of breath. Acute chest pain and shortness of breath, the most important thing that you're going to be looking at is for a STEMI. Second most important thing, probably a PE, right? Because those are two very deadly conditions. STEMI more than a PE likely, unless it's a saddle embolus, they may have a run for their money, right? But in this case, STEMI and PE are very high up the board, but we don't know what else might be going on, right? Maybe this patient has a pneumothorax. Maybe they have acute chest syndrome, right? Maybe it's someone with sickle cell and they have a history of acute chest syndrome. Maybe it's someone who has costochondritis, just that's that essentially rib cage pain that's reproducible. So if you try to reproduce that pain with a patient, because I've had situations where I walk into a room in the hospital and I say, "Oh, how are you feeling today?" Like, "Yeah, I have a little bit of chest pain." And then all of a sudden the red flags start to go off and you're like, "Okay, this is like a 72-year-old gentleman. Like, am I going to have to figure out how to code someone today?" And then you're like, "All right, is the pain reproduced when I, percuss or palpate the chest, that kind of thing?" And if they say yes, it's more likely some sort of costochondritis. All right. So that's the big thing. But I'm kind of going off topic a little bit here. Going down to this first one, now that we have acute chest pain and shortness of breath, what if the pain is crushing, radiates to the left arm or jaw, and is associated with diaphoresis and nausea? This is our tale as old as time, Beauty and the Beast, STEMI, right? So a STEMI, this is when we have a patient who's coming in that... I'm moving my camera a little too much, sorry. All right, so a STEMI, this is when we have a patient that comes in and they're complaining about that left arm pain, and all of a sudden the attending, his ear kind of, their ear kind of moves a little bit, and they say, yeah, like they're sweating a lot, and the attending's kind of looking over, because this might be some sort of triage nurse or some sort of med student doing the initial interview, right? And then they'll present to the attending, and then all these things, the attending, their hair is going to stick up on the back of their neck, saying, all right, let's do a 12 lead on them, let's do blah blah blah, let's do a troponin, right? And so these are all the things you're going to think of, because in a STEMI, there's a time window, right? You want door to balloon in 90 minutes. Door to balloon meaning when they walk into the hospital to when they are in the cath lab within 90 minutes, all right? And that's the big thing of why emergency room physicians need to be making sure that they're watching this. And at the same time, too, we also want to make sure we're diagnosing this properly, because ACS is technically an overarching diagnosis that includes STEMI, non-STEMI, and unstable angina. All right. A STEMI is an actual emergency where you're going to have to call the cath lab and make sure the attending is awake, and if he's on call but at home, he's going to have to get his butt in and make sure that he's there, right? But if it's something like an NSTEMI, we don't have to wake up the attending. Maybe we can have them come in the morning, all right? Because an NSTEMI is not as true of an emergency as a STEMI. You're still going to do serial troponins, you're still going to do serial EKGs, but an NSTEMI is when we only have tropes that are high but no EKG changes. All right, when we're saying a STEMI, that's officially when we have EKG changes. All right, and then unstable angina, this is when we have pain that's like true angina, right? Because stable angina is when we only have it with exertion. Unstable angina is when we have it at rest. All right. And all of these are somewhat emergencies, but they don't require the attending to come in overnight, right? Because let's say the attending is at home sleeping and she just put her kids to bed and now she's trying to relax and wind down and watch a movie or something, and then we have someone come in with unstable angina, we're not going to wake them up, all right? We're not going to call her in and say, hey, your night's over, come on in. But if it's someone with a STEMI, she's going to have to come in, right? So at this point, those are the big things to kind of consider with a STEMI, someone who has this crushing chest pain. And then another big thing to remember as well, there's the MONA-BASH acronym of all the different things you need to consider in terms of treatment, right? MONA-BASH. Don't be bashful, right? MONA-BASH. So we're thinking morphine, although morphine is contraindicated in right-sided STEMIs, right? Because right-sided STEMIs, we need to make sure that we're getting all the preload we can get. Morphine is going to have some vasodilatory effect, and we don't like that in a right-sided STEMI because we need as much preload, right? O2, so oxygen. We're going to also give them nitrates. We're going to give them ACE or ARB. We're going to give them a beta blocker. We're going to give them an antiplatelet, including aspirin or even clopidogrel or both or everything. Just insert cash, select payment type, just open their mouth, throw it in. Typically, aspirin is the very first thing that you can give someone. If you only have baby aspirin and you're at home, like let's say you know a relative is having a STEMI at home because they're complaining of these classic symptoms, have them take 4 baby aspirin. A baby aspirin is 81 milligrams. Typically, the dose we give in the hospital when they come in for a STEMI is 325. So it's approximately 1 small milligram more than 4 baby aspirin. Just have them take 4 baby aspirin, chew it, and put it under their tongue. All right. That's the fastest way for you to be able to get it into your bloodstream. All right. We don't have to worry about the first pass metabolism going through your liver, having it take 30 minutes just for absorption, right? None of that. We're also going to give them statins. And some of these are lifelong as well. Beta blockers, ACE, ARBs, statins. These are pretty much going to be lifelong for them once they have their first STEMI, especially the statins. All right. And then heparin, because we want to prevent any further clotting and try to help those coronaries out as much as possible. All right. And then one last big thing to remember here is atypical presentations. And by atypical presentations, it's kind of a misnomer, right? When we have, like, they'll say silent MIs. Silent MIs is when you have someone who's, for example, like a diabetic, right? Diabetics, they have a lot of neuropathy, a lot of nerve issues. They can have something like gastroparesis, where they can't swallow things, or not swallow, but I guess digest things fast, so their stomach is backing up a little bit, right? But they can also have neuropathy when it comes to the heart and pain receptors and pain nerves in this area, so they might not feel that chest pain, right? So they'll have no chest pain, but they'll have maybe a couple of the other symptoms like feeling uncomfortable, sweaty, all these other things that we think of with a STEMI, all right? And this is why anyone who comes in with abdominal pain and they're relatively older, like 40 plus, they're always getting an EKG anyways, because a lot of times patients will also come in with some sort of pain that's not necessarily arm pain, left arm pain, right? So women and elderly are very classically not going to have the left arm pain, that chest pain, right? It's going to present a little differently. And so this is a complete disservice if you're just saying, oh, you have abdominal pain? Okay, we'll just have you sit in bay 3. We'll do a pregnancy test on you, and then we'll see if we're going to do some sort of CT scan. And you come back 20 minutes later, and they're coding because they had a heart attack the entire time. All right, so these are the things that you want to make sure you're looking out for when someone has maybe a presentation of an MI. All right. Let's move on to the second presentation. So again, I have to remind myself, I've been talking so long. So we have acute chest pain and shortness of breath. But now we have a sharp pain that is worse with inspiration and improves when sitting forward. And maybe I'll tell you that they have EKG changes, right? Maybe they have ST elevations in every lead. Maybe they have a friction rub on auscultation. This is pericarditis. All right. Pericarditis is a different picture that we need to treat. Still relatively an emergency, but not a STEMI where we need to call the cath lab. This is something that you can treat in the ED and then probably consult cardiology to make sure that they get put onto the cardiology service. Some hospitals are different about how the services work. My hospital that I rotate at, we have a floor that is dedicated to cardiology patients. So the CACU, the CICU, those are all patients that are just cardiology related. But then you may also send them to the normal medicine floor. Some hospitals might be where they only have medicine floors, and then the other services are consult services where they come and see their patients, but they're on normal medicine floors. So it depends. But in pericarditis, this is where we have some sort of viral inflammation or some sort of autoimmune inflammation, right? The Liebman sacs, right? Autoimmune, something like when we have lupus, we're going to have those Liebman sacs. Endocarditis, if anything. But in this case, pericarditis is a little different. Sorry, I'll take that back a little. The Liebman sacs is endocarditis, which you can have with, it's a sterile endocarditis you have with something like lupus. Pericarditis is inflammation around the heart, not inside. Endo meaning inside, peri around the outside. So if we have inflammation around the heart, we're going to have, EKG changes on every lead. This is where they'll say the STEMI in every lead. There is no such thing as a STEMI in every lead. There should be reciprocal changes somewhere, right? Even if you have triple vessel, there should be reciprocal changes somewhere. But if every lead has EKG changes, it's likely pericarditis. You can also see the friction rub improves when sitting forward, right? In this case, a lot of times pericarditis is treated conservatively. We'll give something like NSAIDs, colchicine, right? Fluids, or stop the offending agent, depending on what it is. Maybe you need to give dialysis, because something like uremic pericarditis is when you have such a high BUN that we have platelet dysfunction, we'll have pericarditis, right? So the higher it goes, the more of a risk we have for pericarditis. It's common in patients who have end stage kidney disease, right? CKD can have that. But you can also potentially have it in someone who has like HUS or something. Likely not going to happen because it's a young kid, but HUS can also have very high BUN levels. All right. So these are all things to consider. And you want to make sure you're treating them aggressively at the beginning to make sure their pain is tolerated and that you're not allowing any further inflammation to occur. All right. Now, again, let's move on to this next one. We have that acute chest pain, the shortness of breath, and the pain is sudden, severe, radiates to the back. Patient has unequal blood pressures in the arms. These are some of those red flags, right? Unequal blood pressures in the arms. And here's where we can actually break down this differential even more. If we only had the unequal blood pressure in the arms, dissection is something we're definitely concerned about. What about something like a subclavian steal syndrome, right? That's where you're having different blood pressures because there's a stenotic subclavian and you're having to go up in order to get around the subclavian and back down. And if anything, when this is happening, you're having issues with blood pressure in the left arm. Right arm is going to be fine or even a little high. Left arm is going to be a little wimpy, right? So these are things to consider as well. But in this case, I'm really nervous for a dissection. All right. When we have a sudden severe pain that's radiating to the back, right? Maybe they have nausea, right? That's another thing that we can think of. We can have some sort of unequal blood pressure in the arms, but as well as maybe some sort of abdominal pain. If it's a AAA that's dissecting, then it'll be a little lower down with the abdominal pain. But in this case, we have thoracic pain. It's a true aortic dissection, but I'm nervous about an aortic dissection. All right. Big thing here with an aortic dissection is the lumen aspect, the luminal aspect, right? Because we're having this tearing of the lumen, but it's not really creating this full, it's like having this like false lumen that's happening. And we have this medial layer, right? The intima is tearing. Now we have a medial layer that's filling with blood, and we have a false lumen. All right. The big thing here, we want to see what type of dissection is it, right? Is it a type A or type B? Type A is going to be a surgical emergency, and this is the proximity in the aorta, right? So type A is going to be very close to the aortic valve and before the aortic root kind of turns and becomes the thoracic aorta, right? That's a type A. Type B is after we've reached some of those initial structures after subclavian. Now we're going back down and becoming a thoracic aorta and abdominal aorta. That one we treat with antihypertensives. So A, surgery. B, antihypertensives. And you may need to take this patient to surgery anyways, but at least the initial treatment is antihypertensives. And I say you may need to take them because if we have worsening of other organs, right? Because if this dissection makes it all the way to the renal artery, right? Because this dissection can continue. That layer can just keep spreading. It's not really like the medial and intimal layers are glued together. It can keep spreading and keep disconnecting. So in this case, it can make it all the way to the renal artery. And in that case, you're going to have some sort of picture that looks like renal artery stenosis because we're not going to have good blood flow into the renal artery. Now we're going to have issues with end organ damage. We may need to fix that abdominal aorta now. So these are different things to consider. All right. Which antihypertensive, you can give them something like esmolol, labetalol. Those are helpful in this case. But typically they're just going to ask like, you know, what should you do or what should we be concerned about in this case? All right. And then things to look out for in terms of risk factors, because this will be important, right? So risk factors we want to look out for, things like collagen disorders, like Ehlers-Danlos, right? Maybe Marfan, right? We're going to want to look for patients who have like a chronic history of hypertension, right? Maybe some sort of bicuspid aortic valve. Something like Turner syndrome can have a bicuspid aortic valve. Bicuspid aortic valves is not the only thing Turner syndrome is associated with, but it's something that we definitely need to be considering. Potentially even pregnancy is something where, we always have this postpartum pericarditis picture we can look at, or cardiomyopathy, right? But in this case, sorry, not pericarditis, cardiomyopathy, postpartum cardiomyopathy. But in this case, we could have some sort of issue where now we have some sort of dissection as well, right? So these are all things that we want to make sure we're looking out for with someone who has a possible aortic dissection. You're going to want to take them to a CT right away, and you're going to want to check to see CTA typically. You're going to want to check to see what does that aorta look like. Where is this false lumen happening? All right. So in this case, treat them ASAP. Moving on to this next one. Again, we have the acute chest pain, shortness of breath. Now the pain is pleuritic. Tachycardia is happening, hypoxia, and recent immobilization or surgery. Now we're concerned of the progression of a DVT into a PE. And this is the other big one that we want to make sure we're not missing. When we have someone with a STEMI, we also want to make sure a PE is not being missed. This is a very common thing that can have a patient come in with acute chest pain and shortness of breath, all right? The PE, we have some sort of clot that is now forming in these pulmonary arteries. The small little capillary beds aren't actually able to we're not actually able to switch our carbon dioxide out and get oxygen in. So the patients are going to become anoxic, or I guess hypoxic, I should say, not truly anoxic. They're becoming hypoxic. And then the big thing here is that as this is happening, they're going to feel the need to breathe and breathe faster. And possibly they're going to start blowing off CO2, but they can't actually get any extra oxygen in. So these are some of the cases where we need to make sure we're looking at them very intently to make sure they're not going to go into respiratory failure or something, or maybe they have that right ventricular heave, right? If you have right-sided heart failure when you have a PE, that means it is a massive PE. And this is something we definitely need to treat sooner than later, right? Those are the patients that you might need to give a thrombolytic. Something that we usually reserve for STEMIs, you may need to give them a thrombolytic to hopefully get by some sort of saddle embolus. Saddle embolus meaning like a huge embolus, all right? And when we're considering our workup, we're trying to think of Wells criteria, right? Did this patient have recent immobilization? Do they have tachycardia? Do they have an oxygen that's low, hypoxia? Do they have a reason like hypercoagulability, like cancer or something? These are all things to consider. If our Wells score is greater than 4, then we're going to go immediately to some sort of heparin or something right away. And then we can do some sort of CT, all right? Unless they have a reason not to take heparin. If they have a reason not to take heparin, then maybe we do the CT or give them a different medication on the way. Like we can give rivaroxaban, like a 10A inhibitor or something, but we're going to give something right away. Or if the Wells score is pretty low, let's say something like, a 2, and I'll say severely low, like it's a 2, that's when we do this D-dimer that everyone is like, why do we do a D-dimer? D-dimer is looking for the breakdown products of clots, right? That's why in DIC, it's helpful to have a D-dimer as well, just to make sure we're checking all our bases. But a D-dimer is checking for the breakdown of clotting products. If you are clotting, like in a PE, then you have to also be breaking down the clot. Our body doesn't know when to turn things on and turn things off on like the acute level. So if our body already made antithrombin 3, protein C, protein S, whatever it might be, and we're already naturally having these anticoagulants floating around in our blood, as soon as a factor cascade is happening, we may have a random like anticoagulative cascade also trying to happen at the same time. The problem is in a PE, the cascade happens too fast and too vastly, and we can't actually undo the mistake that we just made. But in some patients, this is just happening randomly, right? Our factor cascade might accidentally activate randomly, but then we also have the anticoagulative process happening at the same time that can undo the mistake, all right? But in this case, this is where we do something like a D-dimer and then possibly do some sort of CT after. And the CT, we're going to look for the pulmonary arteries, see if there's something going on. They might say something like a helical CT or like a spiral. And if not, you can do a technetium VQ scan. Let's say the patient can't have contrast. Then you can do a technetium VQ scan, and that can also help see if there's any filling defects. You may even see that the CT comes back negative, but this patient has a PE. A VQ scan can also help because right VQ, ventilation perfusion. If we have an issue with, hey, this area seems like it's not getting any blood flow, but I can clearly tell that they're getting airflow in that area, That's when you're having that ventilation perfusion mismatch. Something like a PE could be causing it. All right. Let's move on to this next one. We have this acute chest pain, shortness of breath, and now we have that the pain is burning, worse after meals, and improves with antacids. Well, in this case, maybe the shortness of breath isn't that big of a symptom in, this specific diagnosis, but the acute chest pain, this would be something like GERD, right? And this is not as common, but this is sometimes the diagnosis that people kind of anchor onto, or they frame, right? Oftentimes, if you have someone come in and they're like, yeah, I have this chest pain, like it started last night when I laid down for bed, and all of a sudden the people are like, yeah, you're obese, it's probably GERD, I'm going to send you home with an antacid. And then you get a phone call that the patient drove home and ended up dying on the way home because it was a STEMI, right? So these are the things that you need to make sure you're not confusing and just kind of writing something off for. But GERD can happen. It can have this acute chest pain that occurs with it because the acid is irritating to the esophagus, right? GERD can eventually lead to Barrett's, right? We have that metaplasia that's happening in the esophagus because the esophagus's squamous cells, they don't really have a protective mechanism, right, compared to the columnar epithelium that we have in our GI tract that can secrete mucus, that kind of thing, the goblet cells, right? So in this case, Barrett's esophagus, they're just saying, all right, I'm just trying to save myself. All right, good luck, everybody else. I'm just going to become a columnar cell, and hopefully I can start secreting mucus to hopefully prevent some of this burn from the acid, right? But in this case, when we're thinking of GERD, we're thinking of how we diagnose it. We ask them questions about, like, is it typically when you eat? Is it after you eat certain foods? How is your diet, right? Is it when you lay down? Have you tried any antacids? Have you tried a Tums, right? Tums, that kind of thing. And then from there, you kind of do the workup of, okay, this seems like it's GERD. Let's go along the lines of whatever. And typically for these guys, you may need to give an antacid as like a small short-term relief, but you may need to give them a PPI, right? You may need to give them an H2 blocker. PPI, those are the azoles, not true azoles, but the azoles like omeprazole or pantoprazole, right? Or Prilosec OTC, which is, I think it just means over the counter. But these are the medications that we give to block hydrochloric acid secretion, directly blocking the hydrochloric acid secretion. H2 blockers were kind of on the side blocking hydrochloric acid secretion because we're blocking some of that parasympathetic activation from happening, right? And in this case, the H2 blockers, that's something like Pepsid, this is going to be your famotidine, right? The idines are going to be your H2 blockers. All right, they're also blocking hydrochloric acid secretion. And then from there, something like an antacid is just like in the acute phase, you can give them something to hopefully dilute and or get rid of some of the acidic environment happening in the stomach. All right. And this can lead to an ulcer, that kind of thing. So you can ask when the pain is happening, that kind of thing, right? All right, let's move on to this next one. I think I gave this one away earlier, but pain is sharp, reproducible with palpation of the chest wall. This is, again, the costochondritis, right? Whenever someone complains of chest pain in the hospital, before you hit the code blue button and say this patient's coding, you ask them, is it reproducible when you palpate their chest wall? Or maybe if you rub your hand back and forth along their ribs a little bit, is it reproducible? Right? Because that'll be more of a costochondritis than some sort of true STEMI-like picture of chest pain. All right. When we have costochondritis, since it's just localized chest pain, we're not going to go crazy in terms of things to do, right? We're just going to give them NSAIDs, maybe some sort of anti-inflammatory that also has some pain relief or something, and rest, right? Costochondritis is a very like chill picture. We're not going to go crazy with it, right? We're not going to give them some sort of medication that might have long-term effects in the long run. So we're looking out, is it reproducible costochondritis? All right, let's take it easy. All right. Moving on to this next one. What if the pain occurs suddenly with unilateral decreased breath sounds and hyperresonance on exam? And let's say that maybe our midline airway is now deviated or something, right? We have deviation of our trachea, or we have this issue where tactile fremitus is gone, like that kind of thing, right? Now we're thinking of a pneumothorax. Pneumothorax is one of the big things you don't want to miss when someone comes in with trauma, right? So when someone comes in with a trauma and they're complaining of chest pain, and you're making sure, hey, like what might be happening, you're going to make sure you're listening to their lungs, making sure they're filling properly, right? Pneumothorax means our lung is now filled with air, and it's outside the lung. I don't know if I spelled that correctly. Parenchyma, something like that. But it's outside the lung and it's compressing the lung. So the lung now goes all the way down. You're not going to see air bronchograms or anything, right? Air bronchograms meaning you can see the actual lung tissue going through potentially some sort of, like, typically it's consolidations or something. You can see air bronchograms, but you're not going to see any of the vessels. You're not going to see the lung tissue at all. It's going to be a very black X-ray or CT. Right? And in this case, when we have a pneumothorax, we want to potentially do some sort of needle thoracostomy, right? Or we'll have to do a chest tube as well. But in this case, a needle is like the quick, like, fix, second intercostal space, midclavicular line, pop it in, let the air out, and then switch to an actual chest tube. Chest tube, we typically always put it in the same direction because whether or not it's a hemothorax or a pneumothorax, it'll have the same effect. The big thing here, hemothorax being a blood thorax, a blood spilling into that space, or you can have a hemopneumothorax, in which case you have both of them spilling into the space, air and blood, and that's probably even more deadly. But the big thing here is to look out for some sort of trauma or something, right? The patient will come in, they have a fractured rib or something. All of a sudden they have this pneumothorax that formed. These are the big things that we want to look out for. All right. Moving on to this next one. Again, the acute chest pain, and then we have the shortness of breath. And then what if we have pain that's associated with fever, productive cough, pleuritic chest pain with crackles on lung exam? Well, now we're thinking maybe some sort of pneumonia picture, right? And this is actually convenient that I was talking about the air bronchograms. In pneumonia, sometimes you'll see the air bronchograms going through the actual consolidation where you can see some of the actual lung tissue is still getting some air down there. So it's not all consolidation, but you can kind of see them going through. Whether it's lobar, whether it's interstitial, right? That can guide our treatment, right? Lobar, most common cause of community-acquired lobar pneumonia, or even just in general lobar pneumonia. That's going to be something like a strep pneumo, right? Strep pneumo, we give them a Z-Pak, send them home, Z-Pak being azithromycin. Macrolide in general is a good first start. Ceftriaxone if you need to in the hospital or something like that, but good first start would be something like a macrolide. Or if it's something like interstitial, right? Maybe this patient has some sort of immunocompromised condition, and now we have an interstitial pneumonia. Maybe this is something like pneumocystis jirovecii, right? And in this case, we're going to think of, hey, like maybe they have HIV, right? It could be an AIDS-defining illness. Maybe this is their first thing that they're presenting with to the hospital, and they didn't know that they might have HIV. So these are all things to consider when you're doing this initial workup and trying to figure out what the patient has. Obviously, we're going to be giving them antibiotics. You're going to want to be checking to see which type of pneumonia it is. I should say it's antibiotics if it's a bacteria, antifungals if it's a fungus, or supportive if it's a virus, right? Not too many viruses can actually have some sort of treatment with the pneumonia. COVID, I know they were giving different medications in the past. I know ivermectin was suggested at one point by certain people, not anyone in the medical field, but ivermectin was suggested at one point. Do not take any ivermectin for COVID, or at least until we have research on it. Maybe we can fund some more research for that, right? Aside from that, we want to make sure that in these cases we're treating patients with whatever the appropriate management is. If we need to do a bronchoscopy to determine what the actual organism is, great, let's do a bronchoscopy, get some of that mucus out, that kind of thing. All right. And then again, here's another checklist for how to break these down. If it's a STEMI, we had that crushing chest pain, radiates to the left arm jaw, etc. Pericarditis, sharp chest pain, worse with inspiration. Pneumothorax, the chest pain that has unilateral decreased breath sounds, right? And then what we would do once we're actually seeing what's going on in each of these cases. All right. Let's move on to this next one. Now we're going to have a case where we have loss of consciousness. We have syncope, right? Different things that we can think of with syncope. Aortic stenosis can possibly present with syncope, right? Because we have less blood flow to the brain, and then all of a sudden, if we have some sort of exertion, even less blood flow, we might have aortic stenosis causing syncope. Maybe this patient has some sort of epilepsy, and we don't know that they actually had a seizure. Maybe they had a stroke, and we don't know what's going on, right? Maybe there was some sort of injury, some sort of trauma, and then the patient had syncope right? Because an epidural hematoma can have that initial, you pass out for like a couple seconds first, and you have the lucid interval, and then you officially pass out again, and you won't come back unless that blood is drained from that area, right? So these are different things to consider when we're talking about a sudden episode of syncope. So let's think about this first one. Lightheadedness is also accompanying the syncope, nausea, sweating, and the episode occurred after a prolonged standing or emotional stress. So when we see this, where a patient has some sort of prolonged standing, emotional stress, something where it's not some sort of actual medical emergency of like a stroke, seizure, or hypoglycemia, right, can even lead to that. This is likely some sort of condition where we have a vasovagal syncope, right? Vasovagal is often what we would consider when, oftentimes, a lot of people who see blood and then pass out, have syncope, a syncopal episode, I should say. That's what we would consider as the cause is likely a vasovagal syncope, right? They had some sort of quick flush of emotional response or something, or even prolonged standing can lead to that. So if you're standing for a very long time, people often lock their legs, right? So if you're standing with locked legs, it's going to be hard for your veins and arteries to kind of move blood back and forth, especially because there's some very hard structures that they're trying to get around. So maybe move your legs, bend your knees, that kind of thing, if you're standing with locked legs for a long period of time. Aside from that, again, we have the diaphoresis. This is all going to be some sort of vasovagal syncope. We're not really going to do much, right? Vasovagal syncope, we're just going to avoid triggers. Maybe we can help them with some sort of therapy of understanding like the biofeedback, understanding when they think they're going to have a vasovagal sympathy, right? Helping them hydrate better to make sure that they're trying to avoid these episodes, right? But these are the big things we're going to try to see with a vasovagal syncope, all right? Moving on to our next cause of syncope. What if it occurred immediately after standing up and the patient reports dizziness when changing positions? Well, now this patient might be having some sort of orthostatic hypotension on this differential, right? Or maybe some sort of issue with blood flow actually getting to the heart, or sorry, to the brain. If it was something like aortic stenosis, we would actually see more things on exam. But let's just say we only saw syncope occurring after standing up and then patient reporting dizziness. Then this is probably going to be something a little more simple like orthostatic hypotension. And maybe it's related to one of the drugs they're taking, right? Maybe the patient's taking an alpha blocker, right? Alpha 1 blocker, something like tamsulosin. Maybe they're taking an antipsychotic, right? A lot of antipsychotics have alpha 1 blockade, and it can cause some sort of orthostatic hypotension, right? So these are the things we need to look out for in patients, is making sure they don't have vast orthostatic hypotension from a medication maybe, and then causing some sort of hip fracture, epidural hematoma, right? Because it'd be the worst thing if a patient comes in with a condition like benign prostatic hyperplasia, right? They have BPH, and we're just going to give them an alpha blocker to treat that BPH. And then the BPH, they go home, and let's say they're 72. They go home, they have the orthostatic hypotension, they have a syncopal event, and they die from a subdural hematoma. We ended up killing them much sooner than they would have had issues with the BPH, right? So this is some of the things that we need to kind of keep in mind when we're giving patients medications, is that they should know, hey, make sure you hydrate well, make sure you look out for these symptoms, that kind of thing, all right? And in terms of treatment for orthostatic hypotension, we want to make sure we avoid what's causing it. So if there's some sort of diuretic, if there's some sort of alpha blocker, right, avoid it, maybe lower the drug or avoid it altogether, stop the medication. And from there we can give them fluids, we can give them whatever we need to do. If it's constant orthostatic hypotension, patients who have carotid sinus issues can sometimes have just like chronic orthostatic hypotension essentially. In this case, you can try to give them medications to try to jack up the blood pressure, but it's hard to discharge patients with this. So these are oftentimes the issues they have on medicine floors of trying to make sure someone doesn't have orthostatic hypotension. But let's just say that's why sometimes they'll finagle ways to make sure the patient doesn't have orthostatic hypotension the last time they measure their blood pressure, right? You can put socks on them, give them a ton of water, make sure that their last recorded blood pressure is not orthostatic-y. All right. Let's move on to the next one. And let's say, what if the patient had palpitations before the event and an irregular heartbeat on exam? Now we're thinking of some sort of arrhythmia, right? Arrhythmias are some of the most common causes of syncope, especially in young patients, right? If a young patient had some sort of syncopal episode, we're thinking first maybe it was an arrhythmia or something like that, right? Hokum, while it is seen often, it's not that often, right? So we should be thinking maybe an arrhythmia as well at the same time, like a ventricular tachycardia or something, right? Or a VFib, right? So in this case, with arrhythmias, treat the underlying cause, right? Diagnosis, we'll do potentially an EKG, depending if you have that available. We can do just simple feeling a pulse in the radial artery and trying to see, okay, is it irregular or does it feel different? Can you feel the pulse is sometimes strong, sometimes not strong? Can you see Canon A waves, right? If we have something like complete heart block, in complete heart block, the ventricles are going to be contracting at times when the tricuspid and mitral valves might be open, and in which case the blood is actually going to go rushing back up the venous system, and that's why you'll see these A waves coming up through the jugular vein, right? So that'll be something like complete heart block. But in these cases, you can see these different arrhythmias happening with different symptoms in real time. All right, you're going to treat the cause. Maybe you need to lower their heart rate, right? AFib, if they have RVR, the rapid ventricular response, we can try to shock them back into normal sinus rhythm if possible, but usually if they've been in AFib for a while, then we can't actually do that right away. We need to make sure they don't have a clot first. The biggest problem with AFib is that when you go back into sinus rhythm, your heart is going to be able to contract normally and possibly push out a clot that may have formed where the blood was kind of staying stagnant. All right, so maybe we'll just do lowering heart rate like a beta blocker for now, and then we can cardiovert them later. Or maybe it is a shockable rhythm, right? And then in which case we'll do defibrillation, right? What are the two different rhythms that we can defibrillate right away? You shock them, right? Just immediate clear, That's going to be our VFib or pulseless VTAC. Regular VTAC, we do not do that. You do the workup in terms of possibly lowering their blood pressure, amiodarone, right? And in these guys, we're going to do two different drugs, whether or not it's an atrial or a ventricular arrhythmia in general. Typically, atrial arrhythmias, you're going to get some sort of adenosine action, just because adenosine helps block that AV node, right? And that's the reason why in atrial fibrillation or atrial things in general, not atrial fibrillation, I take that back. In atrial arrhythmias, it's because we have typically some sort of recurrent, re-entrant tachycardia that's happening. Ventricular, we're going to give something like amiodarone. These guys, we want to make sure we're looking out for pulmonary toxicity or thyroid toxicity, right? Special cases, if we see that someone has Wolff-Parkinson-White, we're not going to give them any type of adenosine or anything, right? Because we don't want to have the accessory pathway kick in, that bundle of Kent that they call it. Maybe we're going to give something like procainamide instead, right? Procainamide is going to be a little easier to try to treat with those patients. All right, moving on to this next one. What if, again, acute chest pain, shortness of breath, and then we also have syncope, or sorry, I take that back. We are in the next episode with syncope. So again, we have the syncopal episode, and the syncope occurred with exertion, and the patient has a harsh systolic murmur that radiates to the carotids. This is screaming aortic stenosis at us now, right? So now we have aortic stenosis. Aortic stenosis meaning on exam, we're going to see that as the aortic valve is opening, it'll sound rough and gross, and you'll hear that murmur, and it'll radiate to the carotid arteries because the blood flow is turbulent up towards the carotids. You may feel a diminished pulse, right? So it may feel like, wait a second, it's not really reaching the carotids that quickly or that strongly. You may have the pulsus parvis et tardis, right? In which case it's just a slow pulse. So you'll feel the radial artery, and you'll check when the actual beats are occurring. You can do an auscultation at the same time, and you can say, wait a second, it feels like it's way disconnected in terms of timing, right? In which case that's the pulsus parvis et tardis. You can feel that the pulses are late. So in aortic stenosis, we're going to want to make sure we're diagnosing it. We'll do auscultation, right? We can do an echo. Make sure that with an echo, we're looking for how badly stenotic the valve is. We can do possibly other invasive maneuvers, but the big thing is the only treatment that's reliable is going to be valve replacement. All right. But an aortic stenosis is going to be a patient, probably an older patient. So let's say we have an elderly gentleman coming in. He passed out while he was at church. He stood up and started walking around and was going to read an excerpt from the Bible. And then all of a sudden, as he was walking up to the altar and took a couple steps, he ended up passing out. And it could be one of those situations where, with the exertion, that's an extra reason for the aortic stenosis to kind of kick in further. He ended up passing out from lack of blood flow to the brain. All right. Okay. Let's move on to 5. So, again, we have the syncopal episode. Now we have chest pain, tachycardia, and recent prolonged immobilization. Well, in this case, recent prolonged immobilization, isn't that some sort of clot or something? Well, how would we have a clot tie into chest pain and then also a syncopal episode, right? Where does that kind of come in? Maybe this is a pulmonary embolism, right? A pulmonary embolism could cause hypoxia, or maybe we have, so we'll say a PE with hypoxia, and that was why we had syncope, or maybe we had some sort of stroke that happened, and with the stroke we had syncope, right? A syncopal episode that could have been a seizure, maybe, or something like that. What if we had a patent foramen ovale? Patent foramen ovales are actually very common. We don't actually realize how common they are because patients typically aren't in this position of a DVT turning into a PE, right? It's already rare for patients to get DVTs. It's rare for a DVT to turn into a PE, and then it's even rarer for a DVT to make it into the foramen ovale and make it through and then all the way up towards the brain, right? But it could be a PFO, and that was what actually resulted in our sudden syncope. All right. But in this case, we're going to want to treat the offending agent. Diagnosis, again, we did the Wells criteria earlier, that kind of thing. So maybe a CT, D-dimer, depending on what we're looking for. Maybe we need a thrombolytic if it's a big clot. And in which case, if you're having syncope, it's likely a big clot in the lungs, or it's something that made it to the brain and is causing a stroke. We do need a thrombolytic, right? Patient's going to need to be stabilized depending on what's going on, right? If there's right-sided heart failure, we need to help them out in terms of the right-sided heart failure that's happening with a giant PE, right? Typically, you'll see that with an echo. You'll see right ventricular heave. If they say right ventricular heave, that means there's a giant PE in the way, and the right ventricle is overworking trying to get the blood into the pulmonary arteries, all right? But big thing here, again, treatments, making sure we do some sort of thrombolytic, heparin, whatever we need to do to try to get them back to normal, all right? Moving on to this next one. What if the patient had an episode involving jerking movements, tongue biting, and post-event confusion? Right? This is that post-ictal confusion they talk about. This is now an actual true seizure, right? The big thing to diagnose whether something is a seizure versus maybe PNES versus other things, right? And this is, again, differentials within differentials. If we think PNES, right, because that's non-epileptic seizure, right? In that case, we would check to see, did they bite their tongue? A very common symptom of someone who has a seizure is that they bite the tongue. And so you'll see scarring and bleeding on the sides of the tongue. Maybe they'll have a high CK because with that contraction, the muscle contraction, you can have some muscle damage, right? Maybe they'll have post-event confusion. The only major, epilepsy seizure disorder that doesn't have post-event confusion is Absence seizures, right? Aside from that, every other one is going to have post-ictal confusion. And that means they're going to be like not really sure where they are, what happened, that kind of thing for like 15-ish minutes or something after the event, right? If they wake up and they're hopping and they're like, oh, what just happened? I know I hit the ground, but like, okay, I know where I am. I know who you are. Maybe it's some sort of syncope from some sort of arrhythmia or something, but it's not a seizure. All right. In this case, we're going to do a workup. We're going to do an EEG potentially. EEG, we're going to check for the electrical conductivity. Maybe we're looking for spike in waves. Maybe we're looking for those 3 millimeter, the 3 hertz spike in waves that we look for something like Absence. But we're going to look for a specific area. Maybe we can tell where it's happening, right? Maybe they're having olfactory hallucinations where they're smelling things that aren't actually there. That's a temporal lobe. Or maybe they have automatisms, right? When they're picking at their shirt, picking at something, or doing a repetitive behavior. That's also an automatism. Automatisms also mean temporal, right? Automatism. This is also a temporal lobe, all right? But the big thing here, we can try to do a workup, try to see where it's coming from. We may need to give them an anti-epileptic, right? If it was a one-time provoked seizure, maybe we don't need to. And by provoked, we're going to say like really bad hypoglycemia, some sort of really bad electrolyte derangement, maybe a febrile seizure in a child, right? And with children with febrile seizures, we have the distinction between whether or not it's a complicated febrile seizure. 1 second, I lost the word. Complex. Sorry. Okay, I probably had a brain fart right there with a seizure. Okay, complex. I said complicated, and my mind couldn't shake it. A complicated febrile seizure. In the case of a complicated febrile seizure, we're thinking, okay, what is happening? Did they have the seizure for more than 5 minutes or something, right? Because more than 5 minutes, we're already approaching status epilepticus. We're going to treat them as if it's status epilepticus. Technically, status is when we're hitting like a 15-minute mark, but we don't care. More than 5, we're going to treat it as if it's status, right? Do they have more than one? So I'll say greater than 2 in 24 hours, right? Or did they have focal deficits? Right, because this should just be like a tonic-clonic or something. If they only had the left arm jerking or something, or the left arm was doing something, in that case, that's a focal deficit. That's going to be an issue where we're going to suspect that it's a complicated, complex febrile seizure. And in which case, they have a risk of potentially turning into a full-blown epilepsy. So we're going to want to make sure we're monitoring them, giving them an anti-epileptic, that kind of thing. All right, and in this case, if someone comes in with status, first-line treatment, we're going to give them a benzo right away. Benzo is first line. If that doesn't work, second line, another benzo. Same benzo, just do it again. If that doesn't work, finally you can get into the soft anti-epileptics like fosphenytoin or something. If that doesn't work, then you can get into the barbiturates and then eventually full-on sedation. And you're just going to have them be in the ICU, anesthesia, that kind of thing. All right. Moving on to this next one. What if this syncope occurred after turning the head or wearing a tight collar with transient dizziness beforehand? Well, now we have carotid sinus hypersensitivity, right? Whenever someone has carotid sinus hypersensitivity, they're going to pass out after putting on a tie or something, right? They're going to feel overwhelmed and then pass out every time they put something near their neck. And so for a lot of people, wearing a seatbelt might be obstructive, putting on a tie might be an issue, buttoning the collar to a nice button-down shirt is going to be an issue. So these are the big things to look out for carotid sinus hypersensitivity. What's happening here? This hypersensitivity is triggered by the brushing of our carotid sinus, right? And that afferent signaling, that's the glossopharyngeal nerve. Don't forget that, right? So the carotid sinus, glossopharyngeal nerve. They like to ask that one too. They'll give you the classic signs of a carotid sinus thing, and then they'll say, which nerve carries the innervation for this or something. That's going to be glossopharyngeal. And it's going to be essentially a vagal reflex where now we have bradycardia and vasodilation, essentially, right? But in this case, carotid sinus hypersensitivity, avoid the triggers. Maybe give them water, give them fluids, that kind of thing, but avoid the triggers. Eventually, they may need a pacemaker if it's bad, right? If this is really bad, then and you just can't help it, it just happens all the time. Maybe they'll need a pacemaker just to avoid syncope from some sort of bad vasodilation and bradycardia. But for the most part, just avoid triggers and try to continue life as normal. All right. Moving on to another case of syncope. What if the patient has sudden syncope with headache, focal neurologic deficits, and vomiting? So now these focal neurologic deficits is going to make us concerned, right? We have a headache as well and vomiting, and we had this loss of consciousness. I'm thinking maybe of some sort of subarachnoid hemorrhage or something, right? Something that's a little more scary than the other guys, right? Subarachnoid hemorrhage. Subarachnoid hemorrhage, when we're looking, we're going to try to diagnose. We'll do a CT, non-con. Always do a non-con CT. In this case, you're going to look for that starfish sign, right? Starfish sign meaning the blood kind of goes throughout all the different areas where CSF is. So there's cuts of the brain as you're doing the CT where you'll see kind of looks somewhat like a starfish, but again, just look anywhere where there's CSF and you're going to try to see if there's blood there. It'll come out white on a CT, right? In this case, the patient will typically say they're having the worst headache of their life, right? That subarachnoid headache is the worst headache of their life. The reason they'll lose consciousness, typically blood is irritating to the meninges. No, not irritant. Irritant to meninges. So that's why they'll have that initial syncopal episode, that kind of thing. And then from there, a couple days later, they'll have the vasospasm, right? So typically in these patients, if they have a subarachnoid bleed and then everything gets repaired, everything is fixed, and then 2 days later they have focal deficits again, it could be a vasospasm as one of the areas that was hit by the subarachnoid hemorrhage. We're going to give them a calcium channel blocker, right? Just how we do with Prinz metal angina, right? It'll help with the vasospasm, all right? But in this case, maybe we're concerned for subarachnoid hemorrhage. We're looking out because we see the vomiting, we see the focal neurologic deficits. In this case, we're going to want to make sure we're looking out for some sort of sacral aneurysm that might have burst, and that's what caused it. Do the CT and then treatment. If we need to take them to neurosurgery to fix it, or if we need to do some sort of interventional thing, great. Otherwise, give them something for vasospasms in a couple days, but that's the big thing here. All right. And then again, another workup for syncope, was it a cardiac one, right? Are we going to look into some sort of ventricular arrhythmia? Was it because of aortic stenosis, lack of blood flow to the brain? Was it some sort of orthostatic hypotension because they're taking some sort of antipsychotic, right? These are all the ways that we're going to look for what's happening and then how we're going to break it down. All right. Vignette number 4. Any questions so far? How are we feeling? All good. All right. Awesome. Let us continue. Oops. Rip. All right. I'm going to have to redo the size of this possibly because my screen decided to make something bigger on me. All right. Give me 3 seconds. All right, there we go. All set. Cool. Does it look centered again and like good and you can read the normal words? All right, perfect. So let's continue. Now with this next patient, we have someone who's presenting with acute abdominal pain, nausea, and decreased appetite that began earlier today. We're thinking of a lot of different possible reasons someone might have abdominal pain, decreased appetite, right? Maybe we have appendicitis, maybe we have diverticulitis, maybe we have some sort of Crohn's disease, right? There's plenty of things that can happen here. So let's kind of picture what can happen as we start adding in extra symptoms, some sort of mechanical obstruction, whatever it might be. So first, when we have pain near the umbilicus, later migrated to the right lower quadrant with fever and leukocytosis, this is a clear-cut appendicitis, right? Appendicitis is a surgical emergency. Oftentimes, the true OG attendings will say take them to the OR first. Don't bother doing a CT. Nowadays, I think they do a CT on everyone just to make sure we're looking for the right spot. If someone's pregnant or you're concerned they might be pregnant, you can do an ultrasound. That might help. Kids might also get an ultrasound instead of a CT, right? In this case, that right lower quadrant, we're looking for McBurney's point. Maybe you'll have the psoas sign as you have the patient try to move their leg, their hip, etc. Right? The iliopsoas is a hip flexor, so if we have them do the hip flexing movement, that can sometimes irritate the McBurney point where the inflammation is. Aside from that Rovsing sign, when we're pushing on the left side of the abdomen, and then we still have the pain show up on the right side for some reason, right? So appendicitis, surgery, right? You're going to want to make sure you're definitely doing surgery right away, and then antibiotics. The actual mechanism is that sometimes we'll have like a fecal colith or some sort of appendicolith, right? That's typically some sort of stone or some sort of little inflammatory rock that's happening inside of our appendix. It's blocking the lumen. Or sometimes we can have that lymphoid hyperplasia. Sometimes in kids they'll have like a viral illness, and the lymphoid hyperplasia can happen. Both of those can lead to appendicitis. Both cases you're going to need surgery and antibiotics. And if you don't get it soon enough, you can do an interval appendicitis. Not interval appendectomy, sorry. And that's when, if it ruptured and now you have some sort of abscess that's pooling, right, you're going to need to give them antibiotics, possibly drain it, and then you'll have them come back 6 weeks later for the actual appendectomy. All right. So that's the big thing here. If someone has appendicitis, that's why it's a surgical emergency, to make sure we take care of it now. Or else, if we let it rupture, we're going to have to wait a while because it's such a toxic thing to the abdomen. We need to drain that fluid. We need to give them a lot of antibiotics, and then we'll do an interval appendectomy. All right. And then diagnosis, again, CT or ultrasound, depending on who the patient is, what types of things we're considering, whether or not we want it to be fast. Maybe the CT machine is busy with a patient and you don't have time to wait. You're just going to do an ultrasound and then rush them to the OR, that kind of thing. All right. Let's move on. Second one. Now, instead of that last picture, the pain is severe in the right upper quadrant, occurs after fatty meals, and radiates to the right shoulder or scapula. Now we have some sort of gallbladder picture, right? This could be some not necessarily cholecystitis, because cholecystitis would have the pain with Murphy's sign, right? As we breathe in, it's going to have that irritation when we push down underneath the right side of the rib cage. But maybe this is more of like a biliary colic or some sort of cholelithiasis, right? That we would call it. And then biliary colic. This can lead to cholecystitis, right? Which is officially when we have inflammation, we have wall edema, maybe some air. If it's a necrotic cholecystitis, we'll have air starting to enter the wall of the gallbladder, that kind of thing. But the main reason here, patient probably has some gallstones. Those gallstones, every time they eat a fatty meal, the gallbladder is supposed to contract, right? We're releasing CCK. CCK is supposed to help the gallbladder say, okay, it's time to contract to release bile so that now it can go into the pancreas, go out of the, etc. These gallstones, as the gallbladder contracts, are going to be painful, possibly get lodged transiently, right? So that's why we're having biliary colic. It can lead to cholecystitis, in which case we need to do surgery right away on them, right? These guys are going to look for the risk factors, right? The 4 F's. Fat, female, fertile, 40. So if you see a 42-year-old female that has not reached menopause yet, maybe had a baby a couple years ago and is obese, this is probably going to be like the optimal picture that they're going to ask you of someone who has possibly some gallstones, and then cholecystitis picture, right? In this case, we're going to make sure they don't have Murphy's sign, right? And then we're going to treat the offending agent in whatever way it might be. Let's say they're having a bad diet. We're going to make sure their cholesterol is treated, right? So let's just cholesterol, right? Because we can have two different types of gallstones. We can have cholesterol, or we can have pigmented, right? So if it's cholesterol, we'll treat whatever way we need to treat them in order to fix cholesterol. If it's pigmented, we might need to figure out why they have pigmented gallstones, right? Some patients, the first reason they'll ever come in with hereditary spherocytosis is the fact that they're having cholecystitis. And then when you do labs on them, you'll realize, wait a second, they have hereditary spherocytosis, they have the anemia, they have the water fragility, right, the osmotic fragility test, but they're going to have pigmented gallstones because as the red blood cells are being broken down, that pathway, the heme pathway of breakdown, is going to result where we have bile that's going to be mixed with the pigmented, the pigments, and then you'll get gallstones that'll form there just from the overwhelming amount of pigment that'll end up in the gallbladder. All right. So in this case, we'll do possibly a cholecystectomy and maybe a splenectomy. Right. It just depends on what they have. We're not going to do a splenectomy and cholecystectomy on anyone who has pigmented gallstones, but in this case, for someone with hereditary spherocytosis, if they have cholecystitis, they're going to need the cholecystectomy, right? That's an emergency you need to treat within 72 hours. And then maybe they'll need a splenectomy as well, just to prevent the lysis of their red blood cells, all right? Remember, that's an anchorin protein deficiency, and that's why in hereditary spherocytosis we have that issue, okay? Moving on to our next one. What if the pain is in the right upper quadrant with fever, jaundice, leukocytosis? Well, now we're in a different quadrant. This could still be appendicitis, right? Especially in a pregnant patient. If this is a pregnant patient who has right upper quadrant pain, fever, leukocytosis, not the jaundice, I'll take back the jaundice, but fever, leukocytosis, right upper quadrant, that is classic for appendicitis, right? Because in pregnant patients, the colon is going to move around a little bit, and the appendix ends up sometimes near where the liver ends up. So in this case, I would think appendicitis for a pregnant patient, but we have jaundice here, so this is not going to be appendicitis. Now we have something like cholangitis, right? Cholangitis, we're looking for Charcot's triad or Raynaud's pentad, right? When we're thinking of Charcot's triad, we're thinking of the right upper quadrant pain, fever, right? Jaundice. And then if we add in altered mental status, hypotension, then we're going to get Raynaud's pentad. And it's adding in all these other things as well, all right? And then in this case, we're going to really make sure we treat them aggressively with antibiotics, that kind of thing. And let me put cholangitis, right? Ascending cholangitis, acute cholangitis, whatever you want to call it in this case. It's inflammation, infection of the biliary tree, right? The obstruction of the common bile duct is now allowing for some sort of infection, right? Choledocholithiasis, which is the blockage from some sort of gallstone of the common bile duct. And now we have an infection that's happening, all right? This case, it's also going to be some sort of treatment emergency, depending on what it is. They may need surgery. They may need some sort of endoscopy to do like an ERCP, MRCP, depending on what's going on, in order to be able to open things up. But in this case, we want to make sure we're giving them antibiotics. And you want to do broad coverage typically for this. And then from there, we're also going to want to make sure we're watching fevers, or we're watching chills, because these are some of the symptoms they're also going to present with. So you can give them antipyretics, right? That kind of thing. ERCP is good for diagnosis and then drainage, not MRCP, ERCP. And that'll help. Although you got to make sure you're also remembering ERCP is possibly one of the causes of pancreatitis, right? That's one of the most common causes of pancreatitis, right? Because we have the acronym for pancreatitis, ERCP is the E. All right, but in this case, again, antibiotics, ERCP, and make sure we're looking out for cholangitis in general. Moving on to this next one. What if on top of this we have the pain that's epigastric, radiates to the back, and is associated with elevated lipase levels, where now these lipase levels are 3 times the upper limit of normal, right? This is going to be pancreatitis. All right. And the big thing here with pancreatitis, if we have an ALT that's greater than 150, that is a really good sign for it being a gallbladder, or sorry, gallstone, a gallstone cause of pancreatitis. All right. So then maybe we'll do an ultrasound and see, oh, they have a lot of gallstones. This is going to be a surgery and remove the gallbladder, etc. Right? Because the big picture here, if we have a pancreatitis that we cannot remove gallstones with, we may need to do surgery. We may need to do ERCP just to open things up, etc. But lipase is good to also check. Amylase is not as good to check. Amylase is not the only place being released in terms of the pancreas, and not as sensitive for pancreatitis. Lipase will be a little better. You can also have alcohol that causes pancreatitis, diabetic disease where you just have chronic inflammation, that kind of thing. So all these things can be from pancreatitis. Hypertriglyceridemia, right? There's a lot of different causes of pancreatitis. And in this case, we're going to want to make sure we're treating them appropriately, right? You're going to make them NPO for a very short amount of time, right? Research used to say, or I guess we used to do NPO for like, NPO for 2-3 days, whatever, just make sure they're better. Also, for those of you who aren't really sure what NPO means, it just means don't give them anything by mouth. Don't let them eat or drink. Nil per os is what it stands for in Latin. But the big thing here is that we're just saying don't let them eat or drink. Just give them everything through the IV that they need. But nowadays, the sentiment is leave them NPO for a tiny bit of time. And then once they're comfortable, give them food again. We're going to give them pain medications, right? And then treat offending agent of whatever type it might be. And then the fun one that everyone loves to remember is scorpion bites, right? Scorpion stings, I should say. So yeah, like this random person in the middle of Maine where there's probably never been a sighting of a wild scorpion is going to come in with a scorpion sting, right? So in this case, that's the one that everyone remembers, so that when the attending asks them, like, oh yeah, what do you expect are causes for pancreatitis? And they're like, scorpion sting, right? No, you're going to want to go through the acronym in general, maybe say things like ethanol, trauma, pancreatistivism, that kind of thing. All right. And then diagnosis is going to be made possibly with CT, possibly with ultrasound, depending on what you're looking for. All right. Ultrasound. Cool. Let's move on to this next. Now, instead of that pancreatitis picture, we have pain, burning epigastric region discomfort that improves with food but returns a few hours later. So now we're basically saying this patient has pain with eating and then, relief with eating and then pain with fasting. So now we're going to figure out, well, is this some sort of duodenal ulcer or gastric ulcer, right? And then we're going to say eating. Let me do eating and then fasting. All right, so to break this down, with a duodenal ulcer, if we eat, it's going to be relief, pain relief. Why? Because typically, if we have hydrochloric acid that's being pushed out of the stomach, because the pyloric sphincter, it'll kind of open up slightly, allow some hydrochloric acid to come out little by little. When we eat, now our pancreas is going to secrete that nice bicarb-rich fluid. It's going to help get rid of that hydrochloric acidy type environment, right? So it's going to be nice and relieving every time we eat. So patients with duodenal ulcers will actually typically get fat, is what we kind of say. They'll eat a lot because it helps. It relieves the pain. All right, so they'll come in pretty fat. Fasting is going to be painful for these guys. All right, and then gastric is the opposite way, right? Because gastric, that means the ulcer is in the stomach itself, and every time we eat, our stomach is going to secrete more hydrochloric acid. So that means it's going to irritate that ulcer further. So in this case, it's going to be painful when we eat. And so people with gastric ulcers will come in and they'll say they lost weight, right? They actually lost like 5 pounds over the last month and they've had this intense abdominal pain, right? And then they'll get relief with fasting because the longer you go without eating, the less hydrochloric acid will be secreted and the more relief you'll get in terms of your stomach not being burnt in the lining, all right? Big thing here in terms of management. Diagnosis, you're going to want to make sure you do an endoscopy possibly, and that'll actually also help with management. So the most common cause of a duodenal ulcer is H. pylori. So you're going to want to make sure you do an endoscopy with biopsy before any treatment, especially if you think it's a duodenal ulcer. In general, for both of them, you're probably better off doing it without treatment first. But if you, let's say you want to do any type of diagnostic testing, you think it's H. pylori, you can do that hydrogen breath test, right? Because H. pylori, urease positive, it's going to break down the hydrochloric acid that we typically have and urea, and it's going to be able to break down things to make it a less acidic environment so it can live better, right? In this case, when we have the H. pylori that's able to live in our stomach, but then we give someone a PPI, right? A PPI, which is part of the quad treatment nowadays. I think quad is probably where we're going to end up. It's better to give someone 4 different treatments than only 3. So with quad treatment, we're giving them a PPI. That's going to be less hydrochloric acid secretion. So that urease isn't going to be as helpful anymore. So we're not going to get the hydrogen breath test, right? So these are some of the things we need to make sure we're taking into consideration if we're going to do an endoscopy on someone, is not actually getting a false negative because we gave them treatment beforehand. All right, and then with that, if it is H. pylori, then you're going to want to make sure you're giving them quad therapy, right? Quad therapy, we're going to give antibiotics, bismuth, PPIs, all that kind of stuff. All right. And then the big thing here too is we want to make sure we're treating this fast. Maybe it was brought on by NSAIDs, right? NSAIDs can cause gastric ulcers. We're going to tell the patient to stop the NSAID, stop the offending agent. And we need to treat it fast because they can have a perforation, right? Eventually a perforation will be a much more serious condition. And in this case, this patient had a duodenal ulcer just from the fact that it was improving with eating, like I mentioned earlier. But NSAIDs, something that might cause the ultimate perforation, that's now a true surgical emergency. We need to repair that lining wherever it might have torn. All right. Moving on to this next one. What if the pain is sudden, severe, and the abdomen becomes rigid with rebound tenderness? Now we probably had some sort of perforation, right? We've officially gone beyond what this initial duodenal ulcer might have been. And now we officially have something worse, like some sort of perforated ulcer, or if it's somewhere lower in the GI tract, maybe it's some sort of perforation in the colon, but this is a perforation in general. All right. Perforations are extremely painful. They're going to have air under the diaphragm, right? So that's like the big thing here is you're going to want to look for a black line or some sort of black spacing underneath the diaphragm, right? The diaphragm, the curvature underneath the lungs, is supposed to have the liver right up against it, or maybe even the spleen and stomach right up against it. If you can see a very thin line of black air underneath it, that's from some sort of perforation. All right. And that's a surgical emergency. We're going to have to take them to the OR and try to find where this perforation is. They're going to have to run the bowel, that kind of thing. But they're going to have rigidity, rebound tenderness, right? These patients, at least the way that we were taught to try to get some of a true rebound tenderness on exam, oftentimes you'll just bump into the stretcher and see if the patient like groans like, oh, that kind of thing. It's hard to get a patient to untense. Like if you're pushing down on their abdomen to palpate and you're like, all right, like, and then pushing, like sometimes they'll just tell you like push really quickly and see if when you release it hurts them, but it's hard to get them to avoid constricting their like contracting their stomach muscles when this pain is happening. So if you just bump into the gurney, sometimes that can help because they're not expecting it, and then all of a sudden they'll complain of pain. All right, but in this case, surgical emergency, and we're gonna need to make sure that if we need to treat something, we're doing it right away. Like if they're taking NSAIDs chronically, stop the NSAIDs. If they had an H. pylori ulcer that now became a perforation, treat the H. pylori, that kind of thing. All right. Moving on, what if now the pain is crampy with abdominal distension, vomiting, and inability to pass stool or gas? That is a major red flag, right? If we can't pass anything out of our anus, out of our rectum, then we likely have some sort of obstruction, right? An obstruction is very bad because we need to undo this obstruction ASAP to prevent some sort of long term, maybe we'll have toxic megacolon or something else happen, right? But with a small bowel obstruction, we need to make sure obstipation is when we have like the inability to pass stool or gas, but we need to make sure that they are passing stool and gas as soon as possible. Some small bowel obstructions we can treat by just putting in an NG tube. Typically, you're going to do imaging, and on imaging, you're going to see that there's just nothing after a certain point, right? So you can do a CT with contrast, and you can do like oral contrast or something, and you'll see that there's nothing going after a certain point. Do not give these patients an enema or something that'll cause them to go to the bathroom, because you need to make sure that it's not something that you need, like a mechanical obstruction that you need to do something about, right? You need to check and verify first what's going on. Maybe you can do an NG tube. Maybe you might need to do surgery, that kind of thing, right? If they have some of the signs of, like fevers and rebound tenderness or things like that, maybe it's something a little more serious now. But again, it can happen from a lot of different things. Adhesions can cause a small bowel obstruction, a hernia, right? If we have some sort of strangulated colon, something like that. Maybe some sort of tumor. A tumor can result in an issue there, right? But the big thing here is we want to make sure we're doing a CT, making sure we see where it is, and then treating whatever is going on, right? Maybe an NG tube is good enough. Maybe we need to do some sort of surgery, surgical evaluation, etc. All right. But again, small bowel obstruction, very serious, and we need to treat it immediately. Moving on to this next one. What if the pain is diffuse and severe, but the abdominal exam appears relatively mild compared to the patient's pain, right? Well, whenever we have mild exam compared to severe out of proportion pain, it's usually coming from some sort of ischemia. All right. So in this case, maybe we have acute mesenteric ischemia, but some sort of mesenteric ischemia is going to be extremely painful, and then we'll do an exam, and it's just, we're not really feeling anything. There's no real like pain with palpation or sorry, there's no real pain with palpation that we would expect, but they're like all of a sudden like screaming in pain that they have acute mesenteric ischemia that's causing this severe pain, right? Or maybe some lactic acidosis, right? So they'll have the severe pain, they'll have the diffuse abdominal pain that's like all over their stomach, and we're like, yeah, but like I thought you said it was the right upper quadrant. Like, no, it's everywhere. Right, and it could just be that we're essentially throwing out little emboli throughout all the different parts of the superior mesenteric artery, inferior mesenteric artery. Depends on where we're having this mesenteric ischemia. All right. In this case, we may need to treat the arterial embolus, give the patient heparin, that kind of thing, or if they can't have heparin, then figure out something else. Right. Typically, we're going to do some sort of CTA or something. Right. Do some sort of like mesenteric angiography. Mesenteric angiography will help us see where we have issues in terms of the blood flow, that kind of thing. You may need emergent vascular, some sort of surgical referral, right, for surgical management. But in this case, we're going to want to make sure we're trying to get this GI tract back up and running as fast as possible, right? Because we do not want this bowel to die and then have necrotic, infarcted bowel that we need to do a major surgery for. All right. And let's move on to this next one. We have pain that is in the left lower quadrant with fever, and then a history of chronic constipation. Right, chronic constipation is possibly concerning for a few different things, like if the patient has a history of diverticulitis, maybe they take opioids, maybe there's just a congenital or I Hirschsprung, sure, congenital Hirschsprung, but maybe this patient has some sort of IBS where they have constipation, right? IBS isn't just diarrhea, can have constipation as well. So in these cases, we want to make sure we're looking out for what we could have. In this case, is going to be diverticulitis. Diverticulitis, again, that diverticula is typically going to form that pocket that's forming in our colon. Typically, it's going to be sigmoid, just because the sigmoid colon is not only the thinnest colon, but also the least supplied in terms of blood flow. You're going to have left lower quadrant pain, fever, that kind of thing. And then from there, we're going to have some sort of false diverticula that's happening that's now inflamed. You probably shouldn't do a colonoscopy on them because you may perforate the bowel when you do that. All right, and this is a common thing in a lot of elderly folks. Diverticulitis, you're going to need to treat them with antibiotics. You may need to drain the abscess. Right, if it's a large enough abscess, you may need to drain. Right, abscess. Sure, why not? You may need to drain the abscess. Right. And it can happen from a lot of different things. It can happen from a change in bowel, like normal habits where they're eating different foods and now they're having constipation again, that kind of thing. But you're going to look out for some of those telltale signs of fever, lower left quadrant pain, constipation, etc. All right. And treatment, again, we're going to make sure giving them bowel rest, right? Making sure they're not eating right away. Surgery if you need to, some sort of abscess drainage if you need to, etc. All right. And again, this is now our workup for the abdominal pain category. And just when you thought that was enough for abdominal pain, but wait, there's more, right? Now we're moving on to another section of abdominal pain, but we'll be coming back after a quick little break. So moving on to this next vignette, we're going to have someone who comes into the emergency department with acute lower abdominal pain. So another section of abdominal pain, right? Because abdominal pain, so non-specific if someone just says they have abdominal pain. But now with that abdominal pain, they also have nausea and vomiting. Oh, well, great. Also non-specific symptoms, right? A lot of things could be going wrong. So what if the pain started near the umbilicus, migrated to the right lower quadrant with fever and leukocytosis? We did that one last time, right? But the reason why we're doing this now is imagine this is maybe a young female that's coming in with this, because now we're going to check the appendicitis versus a couple other things in a young female. Right, because the big thing here is now our differential is going to explore a different route, right? Some possible different options. So again, appendicitis, do a CT, ultrasound, whatever you need to do. Treat them, emergency, surgical emergency, not emergency as in like right now, open them up in the ED, but surgical emergency as in like within a couple hours, try to do the surgery because you're trying to prevent some sort of rupture of the appendicitis, and then they'll have to come in for some sort of delayed, interval appendectomy, that kind of thing. All right. Now let's move on to this next section where, again, it could be this pain that's in the, right lower quadrant or something like that. And if the woman's a reproductive age woman with a missed menstrual period, vaginal spotting, unilateral pelvic pain, And it could be this right lower quadrant pain that it's actually presenting as. Now we have something like an ectopic pregnancy, right? Because in an ectopic pregnancy, we're going to think of this patient possibly having some sort of issue where now we have an ovarian blood flow issue, right? And with an ectopic pregnancy, this can be a surgical emergency as well, right? Because if we have a ruptured ectopic pregnancy, that's definitely going to the OR immediately. And they need to try to salvage what they can. They may just need to do an oophorectomy, right, on that side. Oophorectomy, removing the ovary on that side. But an ectopic pregnancy, it's going to be it's an emergency in some way, shape, or form, probably. If they don't have the immediate emergency signs, and it's just, I have a missed menstrual period, I have this little mass growing on an ovary, and the things that point towards an ectopic pregnancy, then we can give them methotrexate, right? Methotrexate will help terminate that pregnancy. But if it's a surgical emergency where we have the ruptured fallopian tube and now we have bleeding into the abdominal cavity, that's going to be a surgical emergency. All right. So these patients, you're probably going to do some sort of pregnancy test first, right? Because the most common cause of amenorrhea, missing a period, the most common cause of amenorrhea is just pregnancy, right? And so if you do an HCG and it comes back relatively positive or something, then you're going to say, all right, you have some sort of pregnancy. We do an ultrasound, but we don't see an intrauterine pregnancy. So I'll have you come back in a couple days. In a couple days, your HCG should double. If the HCG doesn't double, or at least go up by a number that we designate as high enough, like 1.5, 1.7, whatever we're considering, this is likely an ectopic pregnancy, right? Intrauterine pregnancies will have an HCG that doubles every few days, usually at the beginning, right? Eventually, it's not going to keep doubling because the number is going to get so high, but in the beginning, it's going to double every couple days. So if it's not, it's probably an ectopic pregnancy. That's when you have the conversation of starting something like methotrexate, right? And then afterwards, you can give like misoprostol or something to help with the evacuation of contents, right? Or it may become the surgical emergency, in which case, once the fallopian tube is ruptured, the ovary is compromised, you're going to have to do some sort of surgery just to try to save what's left, right? So an oophorectomy. But this is actually a very common presentation where someone's going to think, oh, it's just, appendicitis. And then they're going to be wrong because it's actually some sort of ectopic pregnancy, right? Moving on to this next one. Again, picture it as a young female. Pain is sudden, severe, unilateral pelvic pain, right? They have the nausea, vomiting. Is it an ectopic pregnancy? They have an adnexal mass on ultrasound. Well, now what are we thinking when they have an adnexal mass on ultrasound and they have sudden, severe pain, right? That kind of thing. Well, if they have an adnexal mass, you think, oh, this is probably some sort of ectopic pregnancy. Well, moving beyond that, when we have a mass on one of our ovaries and we have sudden, severe pain, but we don't have a rupture, right? Because on ultrasound, we can tell if we have a ruptured fallopian tube. But in this case, if we don't have a rupture, this is probably that mass caused ovarian torsion. Ovarian torsion is extremely painful, possibly going to cause you to have nausea and vomiting, right? And it's because that ovary is twisting and we're cutting off the blood flow to the entire ovary. And this is also a surgical emergency because we can lose the ovary. And then that's going to become ischemic, necrotic, etc. So we need to make sure that we're treating this patient immediately. An adnexal mass could be a tumor, but that's that bridge point that's actually going to put us at more risk of ovarian torsion. So that's the big thing to look out for when you're thinking someone has ovarian torsion. And it's the same thing as testicular torsion, where when you have twisting of that gonadal artery, where the ovary is going to have an artery blood supply that gets twisted, the testes as well getting twisted. When it cuts off, it's very painful. That's the ischemia. And then we need to make sure either we just get rid of the ovary or testicle in general, right? It might be too late, in which case we just remove it, or we have to restore blood flow as soon as possible. All right. In the testes, if it's a male patient with testicular torsion, typically you're going to have that cremasteric muscle reflex that's gone, right? That's L1, L2. But in this case, you're going to have that cremasteric muscle reflex that's gone. So you're going to rub the inner thigh. Typically, the testes are supposed to kind of constrict a little bit because the cremaster muscle is activating, but you won't have that. That's also a good sign to know that someone has testicular torsion. But for the most part, you're going to do the Doppler ultrasound, right? And the Doppler flow is going to be low, so you're going to know that there's not blood flowing into the ovary as it should be. It might not be entirely gone, but a little low. And then in this case, that's what's going to be that surgical evaluation, or emergency surgical evaluation. But again, this is only one branch away from something like an ectopic pregnancy. This is why it's important to kind of keep that differential open and broad to make sure we're not ruling anything out before we actually should consider, wait a second, this sounds more than appendicitis. This actually sounds like ovarian torsion or something, right? Moving on to this next one. Right lower quadrant pain, fever, cervical motion tenderness, and purulent vaginal discharge. Well, now we're moving into the realm of PID, right? Pelvic inflammatory disease is very common in young sexually active females. They may get some sort of chlamydia or something, right? And in the chlamydia, it's going to cause the painful cervicitis. That's why there's cervical motion tenderness. That's the cervicitis. And then as it climbs up through the cervix into the uterus, possibly into the fallopian tubes, now we have this PID that's starting, where they're starting to get essentially an abscess that's kind of forming in the rest of their reproductive tracts, right? It's just this widespread infection that's kind of running rampant. And this is not a surgical emergency, but it's a relative emergency in the sense of we want to preserve their fertility, right? PID is one of the most common causes of infertility because they will get scarring from all that inflammation that happens during PID. And some people don't even realize they'll have PID. They'll have chlamydia and they'll have an extended period of time with just this abdominal pain that they don't realize. Maybe they're not sexually active for a while and they don't realize that one of their old partners was actually the one who infected them. And then all of a sudden, after months of this abdominal pain that they never really got checked out, they finally realize it was PID. And now there's a lot of tubal scarring, and now they're possibly infertile. And so they'll come in for their first workup when they're trying to have children a few years down the line. And then they haven't been able to conceive after like 2 years of trying or something. And you'll do one of these sonographies where you inject some contrast and you check to see the tracts, the uterus, the fallopian tubes, and you'll see that there's a lot of scarring where the contrast isn't injecting well and actually covering the tissue well. So you'll see that there's a lot of scarring there. But PID is a very common cause. You're going to give antibiotics or whatever, to cover what it might be, antibiotics and antifungals sometimes too. Because Candida is also a very common cause of PID. All right. Typically, you can cover for gonorrhea, chlamydia, and Candida, and that's probably a good, picture of the things that can cause PID. You'll probably also do testing just to make sure. And if it's clear that it's something else, right? If there's green discharge or something and you think it's trichomonas, obviously you're not going to treat it as if it's chlamydia until proven otherwise, right? So in this case, you're going to treat them appropriately. And then let's say they test positive for something like chlamydia and you haven't gotten testing on gonorrhea, you treat for both until you get testing back. So treat for chlamydia and gonorrhea until you get testing that confirms they don't have the other one. All right. I think I spelled gonorrhea. No, I think it's 2 E's. Whatever. We'll figure it out. All right. So there's PID. Moving on to this next one. What if the pain is sudden unilateral pelvic pain occurring mid-cycle with mild internal bleeding but stable vitals? All right. In this case, now that we have this picture of, okay, we're in the middle of our cycle, right? This is not because of some sort of endometriosis or something, right? Where we have some sort of pain in the middle of a cycle. This is probably some sort of ruptured ovarian cyst, right? Ruptured cyst. If this was at the end of our cycle and then we had this really bad pelvic pain and it was unilateral or something, maybe we're thinking of middle smirts, right? Which is the ovulation. When we actually ovulate, that middle smirts is going to be very painful. But in this case, a ruptured cyst might be happening where, we have this, mild bleeding. And in which case, typically when someone has vaginal bleeding and it's in the middle of a cycle, they're like, wait a second, why am I bleeding? They'll go to the hospital, that kind of thing. and it's painful. So, concern for different things should be there, but they'll have hemodynamic stability. If this was some sort of ruptured ectopic pregnancy, they would not have hemodynamic stability, right? They'd have hypotension, that kind of thing, right? So, ruptured cyst, that's why you have the hemodynamics that are fine. You have a little bit of blood, right? And for the most part, this one is something where we just kind of give the patient fluids and treat them with pain and then send them home, right? There isn't really much for us to do. The ruptured cyst is already ruptured, and we just kind of give them supportive care. So, pain management, not pain, pain meds, and, observation, I guess. All right. And if they're unstable, like there's some sort of significant hemorrhage, all right, yeah, now it's some sort of surgical evaluation, surgical emergency. But for the most part, hemodynamic stability, that's more pointing towards some sort of ruptured cyst. All right. Now let's see. We have the pain that's severe. It's a tearing abdominal pain radiating to the back in an older patient with hypotension, pulsatile abdominal mass. Maybe they were a smoker on top of that, right? Now we're worried that this patient might have a ruptured AAA, an abdominal aortic aneurysm, right? Typically, AAAs are going to be in an older gentleman who smokes a lot. He's been smoking for years. He has hypertension for a very long time. And then he's a 65-year-old that comes in with severe abdominal pain radiating to the back and has a pulsatile abdominal mass. That's a ruptured AAA. This is a surgical emergency, right? You need to take care of this ASAP just to make sure the patient doesn't die. And they still might die. All right, this is something you definitely need to rush down to the OR and try to get that abdominal aorta back in business. All right. A ruptured AAA is one of the quickest ways for someone to go. So this is definitely something that you want to make sure you're taking seriously. It can be long term if it's just not that big of a rupture, but you want to make sure you're getting it very quickly. And it's in the back. You feel the pain in the back just because the abdominal aorta, typically it's that retroperitoneal space. So that's why it's going to be back pain, not abdominal pain. Although you can have abdominal pain if the lack of blood flow starts to hit some of these abdominal organs, the peritoneal organs, right? And then again, surgical repair. And then the first line treatment, they may ask, like, what's the first step in management? It might just be resuscitation, like aggressive resuscitation in terms of like fluids, right? Because what good is it to rush someone down to the OR if they don't have a pulse, right? Because you need to make sure that they still have enough blood to have a blood pressure to still perfuse the organs that aren't actually being affected by this dissection, or their aneurysm, I should say, the ruptured aneurysm. All right. Moving on to this next one. Now we have a pain that's colicky flank pain, and it radiates to the groin with hematuria. And again, it's still that abdominal pain, this nausea, vomiting, possibly picture, nausea especially. This is probably going to be some sort of kidney stone, right? Some sort of kidney stone, so nephrolithiasis. Right? A lot of different things that can put us at risk for kidney stones. Poor diets, certain medications can put us at risk of kidney stones. Certain conditions can put us at risk of kidney stones, like Leishman syndrome, where we have a lot of increased uric acid. We'll have uric acid stones, right? But there's a lot of different things that we can get with nephrolithiasis going on. We're going to have that hematuria, right? The colicky flank pain, and it's simply going to be flank pain. So if someone has like suprapubic pain, it's at least probably not a kidney version nephrolithiasis. Maybe it's some sort of stone that lodged in the bladder, but it's at least not near the renal pelvis or anything, right? And in this case, a lot of the pictures for nephrolithiasis, we just give them maybe tamsulosin or something just to kind of open up the urethra as much as possible, give them fluids, try to flush out that stone. If it's a larger stone, then they'll need some sort of intervention, surgical intervention, like a cystoscopy or something, just to kind of get rid of the stone. All right. But typically, you can do an ultrasound if it's high enough, or you'll do a CT, right? The CT will be able to look for the kidney stone. And then from there, typically it's just supportive if it's a small enough stone. So fluids, maybe an alpha blocker just to try to open up the urethra as much as possible to help with passing the stone. And then if not, then you'll need some sort of surgical, and by surgical I mean like a urology consult, to have some sort of cystoscopy or something in order to um, fix, take out the stone, that kind of thing. All right. And the big thing here, before you do a cystoscopy, oftentimes the questions that you guys will see is, oh, a patient just had a cystoscopy and then suddenly they have symptoms of endocarditis, right? Enterococcus is very common. E. coli is very common, although E. coli is not going to cause the endocarditis picture too much. It'll cause sepsis, but enterococcus can definitely cause that picture in terms of a UTI and then now some sort of endocarditis. We want to make sure we're giving them antibiotics. So anytime someone comes in, they might have a UTI type picture and we're doing some sort of cystoscopy procedure, definitely going to give them antibiotics just to try to make sure we're not giving them endocarditis. All right. Okay. We're done with this group. So here again, acute appendicitis versus ectopic pregnancy versus ovarian torsion. Like, what are our major symptoms? And then the algorithm. Are we going to do an HCG? Are we going to do an ultrasound? That kind of thing. All right. Let's move on to this next block. Now we have so that's actually a very good question in terms of like, how do we know what things mean? Like jaundice and stuff we hear often enough that we kind of know, but what does pruritus mean? Or, what do all these different words mean where you're like, oh yeah, dyspareunia, like I don't know, or dysdiadokinesia, right? Like they just say a lot of words and they mean nothing until we actually try to learn more. It's helpful just to kind of have dictionaries available, not like literal dictionaries, but like just trying to look up what types of words you're seeing. But I like to do it where anytime I don't recognize a word that's going on, I look it up in that moment and just try to make sure, okay, from now on, I will remember what this is. I don't like doing questions where I did not remember or understand one of the words because I feel like that takes away from my understanding from the question, right? The differential can change completely if someone had something like dyspareunia, which is pain with intercourse, right? So in that case, now I'm thinking more of an endometriosis picture instead of something else, right? So these are the things that I want to make sure, if you have trouble understanding or remembering what some of these words mean, making sure you practice them. There's probably Anki decks with flashcards available that you can just have like the tough words that are hard to remember. But that's definitely something very important, is like practicing, making sure you read up on what are the different words they might use. Because it's not just good enough in terms of the names, like, oh yeah, like, someone had Guillain-Barré syndrome versus Jack Yash Herxheimer or whatever for like syphilis. Like knowing the names, that's just half the battle. Knowing what these words mean that are medically related is the other battle, right? And you can also kind of study what the common branches of words are. So poly means a lot of something. Oligo means a little of something, right? So oliguria, not a lot of urine. Oligohydramnios, not a lot of amniotic fluid. Poly meaning a lot. And then you can start combining these words together. Dipsia meaning thirst, urea meaning urine. So polydipsia, you have a lot of thirst. Polyuria, you're urinating a lot. So as you start learning some of these branches of the words or the base words, then you can start combining them together and you're like, oh, okay, this patient actually has some sort of, issue with too much thirst. Why is this happening? And then you can go down your central diabetes insipidus versus your diabetes mellitus, etc. Perfect. Let's move on to number 6. We have a patient that comes into the ED with sudden shortness of breath, chest discomfort, and mild anxiety that began earlier today. What if the patient had pleuritic chest pain, tachycardia, hypoxia, and recent immobilization or surgery? Again, we did this one earlier, but this is another type of, we're doing a vignette that might have a lot of different things. This is a PE, right? We're going to be looking for that right ventricular heave if it's a large PE. We're probably going to give them thrombolytics if that's the case, because that's a very large PE, probably a saddle embolus at that point. So you're going to want to try to throw anything at them to try to prevent death. If not, if it's a small one, maybe we can just get away with giving them heparin or something. Give them some sort of Eliquis after, right? And then if they can't take Eliquis, maybe some rivaroxaban, right? The 10A inhibitors, that kind of thing. All right. But for the most part, these guys, we're going to treat oxygen, etc., diagnose them with a CT, D-dimer, whatever it might be. Now we're moving on to this next one. Again, those same exact symptoms of the sudden shortness of breath, chest discomfort, mild anxiety, right? Because it's a little stressful when this is happening. And now the patient has wheezing, chest tightness, and symptoms triggered by exercise or allergens, right? Well, there's only two different things that will cause true wheezing on exam. COPD versus asthma is now your differential for true wheezing, right? So in this case, we have wheezing and then we have exercise or allergens that's causing something. This is probably asthma that's triggered by allergies, right? Or some sort of allergen. Asthma, how are we going to diagnose it? We're going to give them some sort of steroid, bronchodilator, etc., and we're going to see response to the steroid slash bronchodilator. Right? COPD would not have response. I mean, obviously, if it's a small child, they would probably also just have asthma, not COPD. I would hope a 7-year-old is coming in with asthma, not COPD. But for the most part, you give them a steroid and a bronchodilator and see, did we have resolution of symptoms? Asthma, yes. COPD, no. So in that case, COPD, you're still going to treat with steroids and bronchodilators, but you're not going to get rid of all the symptoms. In asthma, the wheezing will go away and it'll return to baseline. All right. And that's the diagnostic portion, like making sure, okay, this is what it is. Treatment, you have everything from the SAMAs, the SABAs, the LAMAs, the LABAs, the steroids, right? All these inhalers of different sorts, right? And you may say, oh, if it's just exercise, then maybe take your inhaler 10 minutes before you go on a run. Or if it's specific allergies, try to avoid them, or at least have some sort of inhaler with you if you do need to go into this allergen, that kind of thing. All right. Moving on to this next one. A patient who has productive cough, fever, and crackles heard on lung exam. So now we have a patient that's coming in. We have a productive cough, so that means we're getting sputum out, right? That kind of thing. And with sputum, this is a picture for some sort of pneumonia, possibly, right? Or maybe it's some sort of COPD exacerbation. COPD exacerbations can also have sputum. But the fact that we have fever, crackles on lung exam, we're probably just going to go for a generic pneumonia at first. And then we can work up to see, does this patient have a history of COPD? In which case, this pneumonia is just from a COPD exacerbation. All right. But in this case, pneumonia, we have that consolidation that's probably happening in the bottom of the lung, or it's an interstitial pneumonia. We got to see what it is. We're going to treat those with antibiotics, antifungals, depending on what it might be, that kind of thing. But again, now we're kind of picturing, all right, the third different thing that someone can come in that has shortness of breath, chest discomfort, anxiety, because if you're short of breath and you have pneumonia, it's going to be anxiety inducing, right? It's the same thing with like hypoglycemia. When you have hypoglycemia, that's also going to promote some anxiety where you're going to feel like the stress going on, hyperventilate a little bit. You're obviously going to be in DKA, in which hyperventilating is going to help blow off some of that steam. But at the same time, for these patients that have whatever these chest conditions are with the lungs, it's going to feel like they can't catch their breath. They're breathing faster and faster and faster, and they still can't catch their breath. So this is why we're going to try to make sure we're differentiating pneumonia versus a PE versus a pneumothorax, etc. What if the patient has sudden unilateral decreased breath sounds, hyperresonance? This is now the pneumothorax again. Right. Pneumothorax, there's also two different kinds. There's simple versus tension. Right, simple pneumothorax, maybe it's just someone who was coughing a lot and then they get a simple pneumothorax. If it's small, it's not going to cause any of the midline shift, that kind of thing. Tension is a very large pneumothorax. The entire lung is collapsed and there's midline shift towards the opposite side, right? So these are the kinds of things you want to look out for. Again, you're going to give the needle thoracostomy first, then possibly a chest tube just to make sure, right? Now, what if we have a patient with bilateral leg swelling, orthopnea, crackles, and a history of heart disease? Well, now we have some sort of heart failure picture, right? Heart failure exacerbation. Right? With heart failure, we're going to have the orthopnea. Orthopnea, this is a prime example of what does this word mean? I have no idea what it means. Pnea at the end of a word, like dyspnea, that kind of thing, that means trouble with breathing of some sort. And then ortho is positional. So anytime we see ortho, obviously not orthopedics, but ortho, it's a positional term. So orthostatic hypotension, orthostatic meaning every time we move laying down versus standing up, we're going to have issues with our blood pressure. Orthopnea, when we lay down, we can't breathe, right? So we have shortness of breath laying down. All right. And then again, this patient has a history of heart failure. So this is kind of an expected thing where now they have a heart failure exacerbation, right? We're going to possibly do some testing. We're going to do a BNP. BNP is really good for trying to see if this is heart failure. If you guys remember, BNP, brain natriuretic peptide, ANP, atrial natriuretic peptide, those are both of the things just to try to diurese, right? Because typically when someone has heart failure and then they have remodeling in the heart, possibly after a STEMI, ACE is going to be hyperactive, beta is going to be hyperactive. We're going to remodel the heart a lot. But if anything, BNP and ANP are going to try to prevent some of the long-term effects because they're both diuretics, right? Brain natriuretic peptide is because we have too much volume. And so the brain is saying, hey, let's get rid of some of that volume. Let's diurese. Atrial natriuretic peptide, we have too much stretching in the atria. So again, diurese, hey, let's get rid of some of that. But BNP is our best for testing for heart failure. So if we have increased BNP, then it's definitely a heart failure exacerbation. Typically, these patients are going to need things like furosemide, right? Or some sort of diuretic just to try to get some of that fluid off. You can be mindful of what's happening in terms of if they have really low potassium, then maybe give them a potassium sparing diuretic, that kind of thing. And then if this is like HEF-REF, right? With reduced ejection fraction, there's typically this like pillar of medications that you can give. There's 4 different meds, right? So we can give them beta blockers. And typically there's only 3 beta blockers that are proven to be more benefit with mortality when it comes to like this extensive heart failure. This is going to be carvedilol, bisoprolol, and metoprolol succinate. Not metoprolol. That'd be funny though. Metoprolol succinate. All right. From there, we can also give them an ACE, an ARB, or an ARNI, right? ARNI, that neprilysin inhibitor on top of the ARB, right? So valsartan, that's the ARB, and then sacubitril will be the neprilysin inhibitor, right? So sacubitril valsartan is one of the new meds that they have that's great for patients who have heart failure. Or you can just give lisinopril or something like a normal ACE inhibitor, right? From there, we can give an MRA, right? So that's more of that mineralocorticoid receptor, like blocking aldosterone or something, right? So something like spironolactone, right? And then the last one, SGLT2 inhibitors. SGLT2, that's typically the glucose sodium co-transporter, right? And in this case, if we're inhibiting reabsorption, we're getting rid of a ton of sodium and a ton of glucose. In this case, that's like empagliflozin, right? The flozins. So that'll be good in terms of getting rid of some of that volume as well. These are the 4 big ones in terms of heart failure. All right. Moving on. What if the patient had fever, hypotension, diffuse lung crackles, and severe hypoxia following following some sort of infection or trauma, right? So in this case, what are we considering in terms of our overall diagnosis? Because now this patient is truly, septic possibly. We have some sort of fever, hypotension, but we have diffuse lung crackles, severe hypoxia, right? Now this is ARDS. This is full-blown ARDS, acute respiratory distress syndrome, right? That pulmonary edema that's happening with this ARDS, it could be due to fever, could be due, like the infection, could be due to trauma, right? Could be due to pancreatitis. Pancreatitis can sometimes lead to ARDS, right? We're going to have the severe hypoxia, crackles, all these kinds of signs are going to be typical. And it's because we have a breakdown of the alveolar capillary membrane. Or I should say capillary barrier. Alveoli capillary barrier. All right. So with breakdown, we're going to have issues trying to actually move oxygen and carbon dioxide well. We're not going to have oxygen exchange actually working, right? We're going to have increased permeability, right? And with that increased permeability, we're going to have protein-rich edema, that kind of thing, all right? So typically with these guys, we're going to ventilate them. and try to see if we can treat whatever the underlying cause might be, the sepsis, the infection, whatever it is, pancreatitis, and then while they're on a ventilator, hope that they can recover appropriately, right? And then making sure we're not giving them some sort of barotrauma or something, right? Keep the PEEP low. PEEP, that positive end expiratory pressure, just to kind of talk about why we need PEEP. So when we're normally breathing, when we normally breathe, we have negative pressure. That increased negative pressure is what's pulling air into our lungs. If we are unconscious and our diaphragm is not moving, we're not creating negative pressure. The only way to get air into our lungs is by forcing it with positive pressure. Although, since positive pressure is not the normal mechanism, we can have an issue where we can pop some of our alveoli and cause barotrauma. So that's why PEEP has to be pretty low. We'll usually keep it at 5 centimeters, and I forget the actual units on this one, but we're basically keeping it around 5, trying to keep it low, but it has to be high enough to prevent the alveoli from collapsing. All right, but typically PEEP, try to make sure we're keeping it at the right normal, and then the rate and rhythm of our breathing we have to also keep an eye on potentially. All right, what if this patient also has tingling around the mouth, rapid breathing during emotional stress, but normal oxygen saturation? So the thing here, when we have normal oxygen saturation, that means that we're perfusing well and we have ventilation perfusion that's going well, but we have rapid breathing, right? Possibly we have low CO2, right? Because if we're breathing rapidly, we're going to be blowing off a lot of CO2. So we'll have this respiratory alkalosis. This is actually very common during a panic attack, right? Or some sort of acute anxiety provoking situation, right? A panic attack, which a true panic attack, you can also have dissociation from reality, right? So the patient kind of feels like they're detached from reality. It's a third person experience, right? They can have other symptoms, like maybe their vision just feels weird, that kind of thing. But in this case, a panic attack, you're going to have normal saturation of O2, right? Because you're fine. You're breathing in well, there's good exchange, but the rapid breathing and then the tingling around the mouth, you can also have some neurologic symptoms sometimes from the respiratory alkalosis. And that's where you have that perioral tingling. All right. And then you'll also complain about some of these other symptoms that I was mentioning where, maybe they'll feel dizzy, but maybe they'll also have chest discomfort, the dissociation from reality, that kind of thing. All right. Treatment here, if it's an acute panic attack, you can give them a benzo or something, right? You can try to help them relax and try to help their nervous system kind of calm down. SSRIs, SNRIs are the long-term management, but the acute short-term, you can't really give them some sort of SSRI and hope for the best, right? SSRIs take like 4 to 6 months just to work. Like, for example, if someone's given an SSRI and they come in 2 weeks later and they say, yeah, like it's not really working, I don't think, the first line treatment is just to continue the medication for another few weeks, because you need to hit at least 4 to 6 weeks before you can try a different medication. And let's say the SSRI didn't work at 4 to 6 weeks. The next first line medication is to try a different SSRI or SNRI. All right. But again, the long-term management is either SNRIs or SSRIs. All right. Depression's a little different. Anxiety can have either of these. Depression, you can only use SSRIs typically. The only SNRIs that are useful for depression are things like duloxetine or venlafaxine, and those are specific for more of that neuropathic pain. So if someone has something like fibromyalgia, where they have some of that pain that's associated with possibly some sort of depression as well in their history, then duloxetine is going to be good for that. Or even diabetic neuropathy. Duloxetine is great for diabetic neuropathy, and it helps, if they have depression as well, great, you can give them that as well. But typically SSRIs are going to help there. All right, and then moving on to another one. What if the patient has gradually worsening dyspnea, chronic cough, and a long smoking history with decreased breath sounds? So now this patient has a chronic cough. So we're picturing maybe something like COPD. They have a long smoking history, right? So if we're thinking COPD, maybe we have some sort of COPD exacerbation that can cause this, right? And for a COPD exacerbation, maybe we're looking for like sputum, like things like that as well. But because this patient has the history of a chronic cough and smoking, right, they could have COPD, the emphysema, the chronic bronchitis, whichever picture it might actually be. Because you can have either chronic bronchitis or emphysema as your COPD. But the big thing is attendings don't really separate them. They just call it COPD and then you figure it out later. I had that issue once on one of my OSCEs where I went into the patient room, and for OSCEs we call them as like a simulated patient experience, essentially. So I went in the room, asked them what they had, knew that COPD should be on the differential, but then multiple of my pieces of the differential were COPD, and I said chronic bronchitis versus emphysema, and they were like, no, you only put one of them. Like you don't put both. Like you put COPD twice, and it's like, no, well, they're different forms of COPD. They don't care. You just put COPD once, whatever it is, COPD, and then you put something else probably. Right. But for the most part, COPD exacerbation or COPD in general, they're going to be air trappers, right? So they're going to have issues blowing out air because it's an obstruction, right? As they're trying to blow out, and this is an obstructive pattern, right? Restrictive versus obstructive. Idiopathic pulmonary fibrosis is going to be more that restrictive pattern. Obstructive is where we breathe in normal, but then as we try to blow it out, it's hard to try to blow it out. We have issues maybe with a collapsing system, right? So in these cases, they're going to have hypercapnia, right? Hypercapnia, that too much CO2, right? And it's because they can't blow out the CO2 sufficiently. So in this case, their drive to breathe is going to come from oxygen. And so here's a little tidbit for you guys. The normal drive to breathe is CO2 levels, right? So if our CO2 levels increase, we're going to breathe faster to compensate. And so if you're trying to do a competition to hold your breath, who can hold your breath the longest? Like this is how you can like absolutely smoke your kids in the future. What you're going to do is hyperventilate before you actually do the breath holding spell. When you hyperventilate, you're going to blow off a lot of CO2. And our normal drive to breathe is increasing CO2. It's not actually the O2 levels dropping. It's the fact that our CO2 levels are increasing. So if you blow off a lot of steam first, then you're going to have a little bit of a barrier so that as your CO2 starts rising, you don't actually feel that immediate need to breathe right away, as sometimes we feel when we do some sort of, game of where we try to hold our breath. All right. So that means when, you're trying to beat your kids when you're swimming in a pool or something, and then you're like, all right, who can hold their breath the longest? Just hyperventilate first, go under the water, absolutely smoked, right? And then you'll be able to win every time. But in these cases, when patients have COPD, they have such high CO2 levels chronically that their drive to breathe is actually O2 levels now, because that's the only thing that they kind of have left in terms of managing. All right. So if their O2 levels drop, that's when they'll have the hyperventilation. All right. And typically that's when you'll also see that they're going into respiratory failure. If they're hyperventilating and they still have low O2 levels, then they're probably going into some sort of respiratory failure with the COPD. All right. And again, here's our workup of if we think this is COPD versus a panic attack versus pneumothorax, what you should consider, and then what types of treatments you should do. All right, moving on to our last section of the night, we have someone who's coming in with increased thirst, frequent urination, and fatigue. Right, so then everyone's screaming diabetes, right? Diabetes, but we don't know which kind of diabetes, and we don't even know if it's fully diabetes, right? Maybe they just like pregnant, right? Because you might have increased thirst and frequent urination because you're just thirsty, right? For those of you who watch 1,000-Pound Sisters, when you have that craving for water, because that's like not a normal craving, but then the sister just says, well, maybe you're just thirsty, right? Drink some water. All right. So in this case, what if a patient also has elevated fasting glucose, weight loss, glucosuria? Now we're thinking diabetes, right? This is officially diabetes mellitus. And what type? Probably type 2 diabetes if it's an adult, that kind of thing. But it's the same thing as if we don't know their age and what other things they have, it's just diabetes mellitus, and we'll have to see what's their A1C, what's their ketones, and try to figure everything else out to see what's going on. All right. Diabetes mellitus. If it's an adult, again, we're going to probably be giving them metformin. It's probably type 2. There's a 1.5 because there's a mix of both of them. You can actually get an acquired autoimmune diabetes where you're having issues where the pancreas is being destroyed, but it's at the same time where you also have chronic diabetes and the body is just immune to insulin anyways. So in this case, it's like a 1.5. That can happen in older people as well. But again, we're going to do an A1C, check to see what their A1C level is. You're going to do a fasting glucose. You're going to do a ketones, check to see are they in DKA. And then let's actually real quick explain again DKA versus HHS, right? Because they're two very different things, and people I think get them mixed up all the time of like, oh, if you're an adult with type 2 diabetes, you're in DKA. No, DKA is typically reserved for only type 1 diabetes. So in this case, DKA is type 1. HHS is type 2. All right, from there, With DKA, we have ketones in our urine, right? So we have a lot of ketones. In HHS, we have no ketones or minimal, so very, very low ketones. There's nothing in terms of ketones. All right, you'll have high glucose in both of them, high glucose levels. But in HHS, typically that's the one where you have like extremely high glucose levels. So DKA, you'll have a glucose of like 300, 400, and ketones. HHS, and I'll explain. So DKA is diabetic ketoacidosis. HHS is the hyperosmolar, um, hyperglycemic hyperosmolar state, in which case they have way too much sugar in their urine, right? The glucose level is like 900, not in their urine, too much glucose in their blood. The glucose is like 900, all right? So they're going to come in with similar symptoms where they might have like altered mental status, right? But the altered mental status in DKA is because of acidosis, probably. The altered mental status in HHS is because of hyperosmolarity. All right. So that's a little bit of a difference there, and that's how you can break down the two of them. So if it's an older patient who has a history of type 2 diabetes, you're going to be thinking more of HHS rather than DKA. All right. Treatments are pretty much the same. Treatment, if they're coming in with an acute attack of DKA versus HHS, you're going to give them insulin, right? And insulin until everything resolves, not just the sugar. You might need to give them potassium, right? For those of you who might have forgotten, as insulin reaches the cell, it's going to cause GLUT4 receptors to move to the cell membrane. GLUT4 needs both glucose and potassium in order for glucose to actually enter the cell. You also might need to make sure their phosphate and magnesium and other things are also normal, because insulin is going to cause shifting in of a lot of different products to make different structures, right? Because every time we have a lot of energy, that's when our body decides, oh, let's replicate cells, let's make DNA, let's do our organelles, whatever we might need. So you may need more than just potassium, all right? So insulin, potassium, and then fluids is another big thing, all right? Anytime someone comes in DKA, HHS, whatever it is, fluids just to try to dilute whatever's already in their blood, all right? And then would age also potentially be a factor to consider between type 1 and type 2? On the exam, yes. In the real world, no. Unfortunately, there's 12-year-olds coming in with type 2 diabetes already nowadays. And it's tragic to kind of see like such young kids already presenting with signs of type 2 diabetes. I remember, like, I'm obviously, I'm a medical student at a large university, so one of my rotations was actually at the student clinic on campus, and there was already I forget if they were 18, 19, whatever it was, an undergraduate student at the university who already had type 2 diabetes. And it was probably already happening for a few years. It wasn't that the clinic first diagnosed it, it's just they were coming into the clinic for maintenance medications, like, okay, let's continue metformin, that kind of thing. So in the real world, unfortunately, age is probably not a factor anymore. On a test question, yes. If it's a 7-year-old coming in with diabetes, it's type 1. If it's a 65-year-old coming in with diabetes, it's type 2. All right. Typically, that's how you can kind of picture it. Moving on to this next one, we have a patient with very dilute urine, hypernatremia, and symptoms that improve after administration of desmopressin. Well, what is desmopressin, right? Everyone's like, yeah, desmopressin, that's helping with factor 8, right? Factor 8 release. Well, I mean, it does, but that's not actually what's happening here. Desmopressin is one of those weird things where they're checking to see if you have factor 8 possible. So if you ever hear of a desmopressin test and the patient's, factors don't correct or whatever, they're checking for factor 8. Okay, so in this case, desmopressin, this is diabetes insipidus. And you can actually tell which one it is from the desmopressin test. So what is diabetes insipidus? Insipidus meaning this is some sort of issue where we don't have ADH or we can't react to ADH. So either no ADH or no response to ADH, right? And we have to kind of break it down by what it is. No ADH at all is central diabetes insipidus. Can't respond to ADH is nephrogenic. So in a patient who responded to desmopressin, right, because this patient actually had improvement of symptoms, this is central diabetes insipidus. The reason why we have symptoms in diabetes insipidus is that we can't concentrate our urine. All right. And this can be common after some medications, like lithium is a common cause of diabetes insipidus, although lithium will cause nephrogenic diabetes insipidus. But for the most part, if we can't concentrate our urine, then we're going to have issues with polyuria, polydipsia in general, which it's going to look like diabetes. That's what the concept of diabetes is the polyuria, polydipsia. And then we have to see what might have caused it. Lithium is going to be nephrogenic, though. Central is common after things like trauma or a tumor, right? So those are other things to consider in terms of what might be happening, all right? Let's move on to 3. We have a patient that comes in, also very dilute urine, but does not respond to desmopressin. All right, now it's a factor VIII deficiency, right? No. So in this case, this is the nephrogenic diabetes insipidus. So nephrogenic diabetes insipidus means that our kidney does not respond to ADH. ADH does not activate kidney. All right, so in this case, we don't actually retain any of the water or respond, right? Because ADH, antidiuretic hormone, we're supposed to retain water. We're retaining sodium and whatever else we need to, but we're supposed to retain water. Diuretic, right? We're diuresing, we're removing water. Antidiuretic, we're supposed to retain water. So in this case, if we have trouble retaining water, we're still going to have the dilute urine, etc. Nephrogenic means we don't actually respond to it. So in this case, we're going to try to need to maintain water in other ways, maybe give them aldosterone type things like fludrocortisone. But in these patients, they're not going to respond to desmopressin. And this is very common after something like lithium. All right, so making sure that if a patient's on lithium long term, that they know to look out for these symptoms of, hey, if you ever notice you're drinking a lot of water and you're urinating very frequently, you should give the office a call and we should talk about your medications. All right. And then just really quickly while we're here anyways, lithium toxicity, that we're going to look for things like tremors, GI irritability, so like diarrhea. Right. And then we can also have issues with other organs, right? Someone who's going to take lithium, we should also make sure that they don't have issues with iodine and their thyroid. So there's a lot of different things lithium can affect. Okay. But it is a great treatment for bipolar disorder. So oftentimes we make sure that they don't have some of those conditions that lithium can cause bad things with originally, and then treat them with lithium anyways. All right, what if the patient has excessive water intake due to psychiatric condition and low serum sodium? So in this case, patients can actually drink a lot of water because they mentally think they need to drink a lot of water. This is psychogenic polydipsia. Sorry. Psychogenic polydipsia, it's when someone is just drinking water, obscene amounts of water, right? We have this great thing that evolutionarily speaking, we've developed with time. It's called thirst. So only drink when you are thirsty. But these patients will drink obscene amounts of water. Sometimes it's because they were like following some sort of diet regimen that said you need to just drink water like no tomorrow, right? So like, yeah, like I was supposed to drink like 16 gallons of water a day or something, and they're only on gallon 8 or something. It's like, okay, chill, because you're going to give yourself polydipsia, psychogenic polydipsia. Psychogenic polydipsia specifically, though, is that they have essentially a psychiatric condition where they need to drink more water, and they think that they need to drink more water, even though they really don't. All right, you're going to reach a point where you're too dilute in terms of your electrolytes. All right, especially if it's just plain water. If it's just plain water, you're not going to have enough electrolytes to go around. All right, so psychogenic polydipsia, just withhold water. All right, do a water deprivation essentially, and it'll fix everything right up. All right, moving on to this next one. What if the patient also has kidney stones, abdominal pain, and elevated calcium levels? All right. So when someone now has kidney stones, and maybe it's chronic kidney stones, right, that kind of thing, and they have elevated calcium levels, well, now we have an issue with our calcium metabolism pathway, right? Maybe we have high PTH, right? This patient now has hypercalcemia if they have high PTH. So one of our big concerns is hyperparathyroidism. And if this is a primary hyperparathyroidism, we're just secreting too much parathyroid hormone from the gland, and you'll have high calcium that way. Secondary and tertiary typically will have more of a lower calcium than that. It's mainly because our kidneys are failing. There's other reasons for secondary and tertiary. Typically tertiary is just because you've had such long secondary hyperparathyroidism that you're having from CKD, but secondary is not just CKD. But typically in those cases you'll have like high phosphate, that kind of thing. Typically with parathyroid hormone, we want to increase our calcium levels, decrease our phosphate levels, and this will help when we're eating food that has a lot of calcium in it. If we have parathyroid hormone, it'll activate vitamin D. It'll help increase our absorption of vitamin D through our GI tract, and then it'll help resorb calcium from our bones as well. But in this case, if we have too much of it, then we're going to have an issue where we just have too much calcium in the blood, right? Too much calcium in the blood, that's when you're going to have the moans, the groans, the stones, and the psychiatric overtones. Right. You're going to have constipation, that's the the pain, the abdominal pain, the stones, the kidney stones, right? And so that's typically one of the things where if you have a hyperparathyroidism where you have too much calcium, you treat the underlying condition. But let's say you just have too much calcium in general as your reason for why you have kidney stones, something like a thiazide diuretic can help, right? Because thiazide diuretics are going to cause increased reabsorption of a few different things. And you remember with hypergluc, right? Gluc. That's a bad U. Hypergluc. So it's glucose, uric acid, and calcium. And by increased reabsorption, that means the products, the calcium, whatever it is going back into the bloodstream. So reabsorption meaning it's not getting into the urinary system, the ureters, etc. That's where we get the kidney stones, is when too much calcium is actually making it to the renal pelvis. It actually is getting through the collecting duct, right? In this case, if we're reabsorbing it, then we're not going to have the kidney stones. So this is an effective treatment if someone's having calcium kidney stones that you want to just help them in the short term, all right? All right, let's move on to this next one, where what if the patient has hypertension, muscle weakness, hypokalemia, and they also have issues with, again, the polydipsia, polyuria, then this is probably hyperaldosteronism. Right, there's a primary hyperaldosteronism, which is Conn syndrome, they'll call it. There's also secondary, when you just have an activation of the renin-angiotensin system. Right, primary means that the adrenal gland is doing too much aldosterone. Secondary, maybe you have like renal artery stenosis, and so since the kidney feels like it's not getting much blood flow, you're going to activate the renin-angiotensin system, right? So hyperaldosteronism, aldosterone, again, the mechanism, we're trying to retain sodium in order to get rid of potassium. Sodium is going to bring water with it, so we're going to retain a lot of water when we do that. And in this case, if we drop our potassium low enough, you're going to have EKG changes, right? Possibly get an arrhythmia eventually. You're going to have muscle weakness. And then you're also going to have issues with hypertension because you're retaining so much sodium in water. Treatment here, try to give them a medication that's going to antagonize aldosterone in some way, shape, or form, right? Depending on which type of hyperaldosteronism it is. If it's a primary, then we need to give something that's preventing aldosterone from being activating. If it's a secondary, maybe you can give them an ACE inhibitor, right? That kind of thing. Although if it's secondary, as in like renal artery stenosis, we can't give them an ACE inhibitor because it's actually going to make their GFR increase significantly. But in this case, we're going to want to make sure we're giving them fluids, treatment, that kind of thing. All right. And then possibly even a CT to look for a mass. All right. And moving on to this one. Now, what if this patient has polyuria after starting lithium therapy and the inabilities of the kidneys to concentrate urine? Dun dun, right? This is going to be the nephrogenic diabetes insipidus. Lithium causes this, right? So patients who are taking lithium long term, you're going to want to make sure you're counseling them. Hey, you're going to want to make sure you're looking out for issues with polyuria, polydipsia, just in case. You should kind of think about the side effects of lithium. If we need to ever talk about, hey, if you have tremors, that kind of thing, you should come in. We'll change meds, that kind of thing. But it's just that lithium is a great medication for patients who have bipolar disorder, so it's typically still first line. And lithium is actually one of two medications that are actually proven to reduce suicidality, right? So lithium and clozapine. They're the only two that lower suicide rates. And actually, a lot of you have probably heard SSRIs can possibly even increase suicidality. So, in younger patients, it was possibly shown during the studies that it can increase thoughts of suicidal intention, suicidal ideation. All right. But for the most part, lithium and clozapine are the only two that will reduce suicidality, suicidal intention, that kind of thing, ideation, that kind of thing. All right. And we are done. I hope you guys enjoyed today's session. What do you think? Any questions about what we covered? Thank you. I appreciate you coming by. Hello? What? Oh, yes. What? Oh, so the factor 8 was just a joke in terms of like that's what it's used, but it has nothing to do with the diabetes or anything or the I think I went too far. Yeah, so I can erase the factor 8, but it has nothing to do with this. It's just, in general, desmopressin is one of the tests that you can use, like desmopressin administration, to see if someone will actually have factor 8 secretion from there. It can help you differentiate between different things like von Willebrand factor or something like that, deficiency. But it has nothing to do with the actual diabetes insipidus. In this case, the diabetes insipidus we're thinking of here, central diabetes insipidus, it means that we're not producing ADH. So desmopressin, which is basically ADH in drug form, will help with dilution. Sorry, not dilution of our urine. It'll help with the fact that we have dilution of our urine. So it'll help concentrate the urine.